So, sir, is 3, 2, 1. Over to you, sir. We are live to audience.
Good morning. Again, we are here on second Sunday of the month of February of 2026. And I am glad to inform you that now we are running this program into fifth year. And this year we have our FOSI president, Dr. Bhaskar Pal, and our ICOG chairperson, Dr. Sheila Mane, under whose leadership and guidance we will be continuing this program. And we will be having, as usual, three sections. One is on the doll and dummy, where we try to provide the students all the information and give them the practical tips how to present in the exam about doll and dummy, which is a major component in all the obstetrics. Then we have case discussion, and we take one by one any obstetric case or gynae case. And then third is the development technique, because as per the National Medical Council Commission, the emphasis on the skill-based learning and competency has to be enhanced among the students and our postgraduates. So it is important that we provide them some skill enhancement, and we provide a 30 to 45 minutes on development of skill and a how to do. Basically, that type of videos or practical lectures are being taken under this program. And in the end, we just for the students, just to deviate from routine theoretical or other type of learning, we have a quiz program on the topic of case discussion. So that provides a golden opportunity for the students to learn by different methods. So we are using different methods of teaching learning also. One where we are giving them the demonstration, where then the second is a case discussion where we have a group discussion along with our teachers, and third where we give them the skill enhancements, and lastly we have quiz where we put it is type of MCQ, and we provide brainstorming session with the students, and we see that how they uh, fulfill the correct answer. So there are various type of these teaching learning methods also. So with these all, today, as we have our new team of FOXY, and Dr. Bhaskar Paul is here. So before we start, let's inaugurate this series in this year of 2026. So can we have lamp lighting and Saraswati Vandana?
Yes, sir.
या कुन्देन्दु तुषारे हारे धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना.
So thank you. So today I welcome our FOXI President, Dr. Bhaskar Paul, our ICOG Chairperson, Dr. Sheila Mane, and we are thankful to Dr. Suvarna Khadilkar and Dr. Sadhana Gupta also. Along with that, I have my colleagues who help in providing all the background material and preparation for this FOXI ICOG PG clinic, and Dr. Ashish Murgopandhyay and Hafizur Rahman. I welcome Dr. Pratik Tambe also, who is the Secretary of ICOG. Today we are having doll and dummy with Dr. Rekha Bharti. She is faculty at Safdarjung Hospital. Then we have a case discussion on endometriosis or ovarian endometrioma. Let's see what it comes out to be. And we have, along with Dr. Ashish, Dr. Jodha, Dr. Planiappan, Dr. Pratibha Roy, and Dr. Jaiswar. Unfortunately, she is not joining us today. So we try to have teachers from different parts of the country along with our governing council members. After that, we have mastered the technique where we enhance the skill of the students. We will be demonstrating ovarian cystectomy, open versus laparoscopic, all the technical experts, and this will be done by Dr. Ashish Kale. And in the end, obviously, we have a quiz And Dr. Archana Kumari, she is the chairperson of FOSI Quiz Committee. She will be conducting the quiz program. So before we start, I invite Dr. Bhaskar Pal, FOSI president of 2026, for his advice and guidance.
Thank you, Ashok. And I think messages at academic programs have to be short. But I take this opportunity to congratulate the ICOG leadership. In our organization, the leadership changes every year, but it is very important to continue successful programs. And I think ICOG PG Clinics is an example of that. So congratulations to Dr. Sheila Mane, Dr. Sadhna, and Dr. Pratik for continuing this. Now, this is a program which has been immensely successful, and three eminent teachers, they coordinate this program. Dr. Ashok Kumar, the new hero of AICOG Delhi, Professor Ashish Kumar Mukhopadhyay, one of the most eminent teachers, and the young, energetic Dr. Hafizur Rahman. So I'm sure that this will be very useful to the postgraduates given the format, and I wish you all the best in subsequent programs. Thank you for having me.
Thank you, sir, for your encouraging words. We welcome Dr. Parag Biniwala, past chairperson of ICOG also. Now I request Dr. Sheila Mane, madam. She is the chairperson of ICOG for her inaugural address.
Thank you, Dr. Ashok Kumar. And I'm really happy and I feel privileged to be there today for this, the first inaugural program of our PGCME. And as everybody has told, and I also being a teacher, now almost from more than 3 decades, these academic activities which are for the postgraduates are very close to my heart. And definitely, I mean, we are going to continue it with more zeal and more innovative ideas as new people come in. And Dr. Ashok Kumar, I know you started it since 5 years, and it's really, I must say, it is a start program of our ICOG web series. And the way you have structured it, because, you know, we all being in medical colleges, now we know what are the NMC recommendations even for the post-graduations. So trying to cover or make the students competent to appear for the exams from all angles, and that is very important. And I think today's students are really benefited because sitting wherever they are getting so much of experience, you know, the learning experience, and the way I think we have today's professors or the faculty which is there is from all the zones, like you said, Dr. Jodha, Dr. Palaniyappan, then Dr. Pratibha and Dr. Jaiswar. So all zones. So that exposure is also equally important, particularly even for the NB students, because NB students, DNB students can get any center. They do not give exams in their own parent institute, whereas the MS students may appear in their own, but yes, the examiners can come from anywhere. So I think it is a very good platform, and I wish that we would like to spread our wings more and more and see to it. I think, I mean, I have taken that initiative that this message reaches each and every teaching institute in India, and more postgraduates join these programs and take the advantage. So I wish good luck even to the students, those who are going to present today. That is Dr. Manasa from the KM Hospital and State Medical College, and Dr. Nikhil Arjun, as well as the coordinating facilities, Dr. Padmaja, and who is the professor at KEM and State Medical College, and Dr. Himangi Sudhakar Varke, who is the assistant professor. So thank you for coming forward, the students as well as the teacher from this medical college, and all the best for today's program.
Thank you, madam. We have with us Dr. Suvarna Khadilkar, madam, also. She is the Secretary General of FOSI. May I request madam to say a few words? Please unmute.
Yeah. Am I audible now?
Yes,
Yes,
madam.
ma'am.
Yeah. So, good morning, everyone. At the outset, I just want to appreciate the kind of work that is going on the platform of ICOG. Dr. Sheila, wonderful work. And I like, you know what, the whole program is so concise, brief, and to the point. And this program is on, this postgraduate program is on maternal pelvis and dummy, which is the most closest topic that I have to my heart. And I always, all PG clinics, everywhere, I like to take this topic. And COVID has taught us that even the dummy pelvis, which is actually a live practical session, which can also be done on an online platform. And because unless the students hold the maternal pelvis in their hands and demonstrate various maneuvers, they don't teach, they don't learn. So but we can teach online, they can practice in their respective center wherever they are. And online PG teaching has become so powerful that in one go you can educate so many thousands of PGs. That COVID has taught us, and we are still continuing with the same kind of concept and ideas of educating postgraduate students. And I like the entire KEM staff, Dr. Padmaja, and I see Dr. Students like Dr. Manasa, Dr. Nikhil, and they are going to present on cases on ovarian endometrioma and endometriosis. And Dr. Himangi, all of you are going to discuss this cases. And the faculties like Dr. Ashish, Dr. P.A.S. Jodha, Dr. Palaniappan, Dr. Pratibha Rai, and Dr. S.P. Jaiswar. Each one is postgraduate teacher of great repute, and I wish you all the very best for this postgraduate program. And I would like to personally also take part in all this postgraduate clinic. Dr. Hafiz, you have been doing
Yes,
great
yes. Most
communications
welcome.
since so long. You know that I love PG teaching, and I would be anytime there is an opportunity for me, please include me. I will be
Sure.
more than glad to be a part of this. Thank you so
We'll be
much.
happy to have you
And
next time.
yeah, so
Most
I'm
welcome.
so happy to see all the ICOG past chair, Parag, Pratik, who is current secretary. They are all so passionate about teaching. In spite of finishing that post, he is still right here for every ICOG program. And I see Pam, Dr. Saroj, Dr. Ashish, who are logged in. And I really feel so glad to be with you all. But I am in Bhubaneswar attending endometriosis consensus meeting. So I'll have to leave. Thank you so much. Yeah.
Thank you, madam. Thank you for your kind words. And before I proceed further, let me have the privilege to invite Dr. Parag Biniwala also. He is the past chairperson, and we are happy to see you, sir, today.
Yeah. Thank you, Ashok. Let's not waste any more time. It's already 11:45, so let's go
Yes,
ahead with the
yes, yes.
program.
No, usually,
Right.
sir, this is
Thank
the
you.
first program of the year of a new team, so we thought we can spend 5-10 minutes on this. Otherwise, we straight away start the program without
Thank you.
wasting any
Yes.
time.
Thank you.
So
Thank you
today,
so
just
much.
we have taken the
So
liberty.
just
Dr. Pratik Tambe,
yes,
any words from your
yes,
side?
yes. So just one word, Dr. Ashok Kumar. I would like to also thank Dr.
Yes,
Archana and Dr. Ashish Kale. Okay, and I thank all the governing council members for joining. And it's really very nice, happy feeling to see, and to see that our governing council members.
yes, ma'am. So, a quick word from Dr. Pratik Tambe, sir.
Thank you very much for inviting me to speak. I'm in a noisy environment, so I'll keep it brief. Thank you to all the conveners, Professor Ashok Kumar, Dr. Ashish Kumar Mukhopadhyay, and Hafizur Rahman, who's one of the unsung heroes of ICOG. Thank you for taking this program forward over so many years. I wish you all the very best and keep rocking. Thank you for inviting me here.
Thank you.
Thank you. So I once again thanks all the faculty who have joined, our GC member and other faculty members who have joined for this program and taken means we have made the efforts, and you have taken now we will formally start our program, and he will introduce the program, and then Dr. Hafizur Rahman will run the program. Dr. Ashish, yes.
Good morning, everyone, and thank you, Dr. Ashok Kumar. And everything has been said, everything has been done. Now, the introduction has been, as Dr. Ashok Kumar has said, we have taken a bit of liberty because we are wishing hereby all of you Happy New Year. And it's a good beginning of the ICOG program, which has been running for last 5 years. And you must have noticed that we are constantly evolving in this program. I mean, changes are part of life, a part of NMC also, and part in the student's life also. So it should be always vibrant, it should be always changing. And I thank particularly all the faculty members and the office bearers of FOSI and ICOG. They have taken out time, and more importantly, they have taken keen interest in this program. Although this is meant for PGs only, but I believe all the young gynecologists will benefit it, including the assistant professors and the junior teachers also. They get benefited. I keep receiving calls from all of them. Thank you, Pratik, for joining here. And Parag is exceptional. I wish that he will continue this in this platform and joining silently and contributing his bit. Thank you, Professor Sheila Mane. You have been a wonderful example of inspiration and support. And as always, everyone knows, Dr. Bhaskar Pal is always very energetic, enthusiastic, and innovative in his ideas. So I believe that all of you deserve a big round of applause from all of us, a silent applause, of course. And with that saying, I would like to continue that we are going to evolve this program as and when required by the students. We keep receiving feedbacks from the students, and accordingly, under the guidance of NMC, we will constantly evolving this. Thank you very much for your august presence here, and let the program begin. Hafizur, please start. Thank you.
Thank you so much, sir. Good morning, everyone. I'd like to again sincerely thank you very quickly to Bhaskar Paul, sir, and Sheila Mane, madam, for allowing us to continue these programs. As Ashok sir and Ashish sir said, this is the fifth year running. It's, in fact, is more than that, because initially there was a duration was more. So we had, I just like to, because again Ashok sir said, because it's the first program, so I'd like to thank you all the previous chairpersons, Dr. Uday Thanwala, when we started the program. Then we had Lakshmi Srikant madam, then Dr. Parul Potwala, then of course the immediately just Parag Binyala sir, and now for we would like to thank you Sheila Mane ma'am for continuing this program. So without wasting any time, we would like to start with the first program, that is on mechanism of labor in occipito-posterior position. Now for this program, we have eminent professor, Madam Dr. Rekha Bharti. Madam is professor at BMMC and Safdarjung Hospital, New Delhi. So I would like to request Rekha Madam to start your presentation. Over to you, Rekha Madam.
Good morning, everyone, and I hope I am audible to all.
Yes, ma'am.
You're audible. You're audible.
So as I learned, this is the first class on the occipito-posterior presentation, and we are not doing occipito-anterior. So I'll just divide it into three basically headings. So first, I'll talk about how to diagnose occipito-posterior, a brief introduction to it. Then secondly, I'll demonstrate occipito-anterior so that the students can learn what is the difference between the mechanism of anterior and posterior. And then I'll go about like what are the various mechanism of labor with occipito-posterior presentation. And in the end, I'll talk about the face-to-fuse delivery. So first of all, clinically, when do you suspect that it is occipito-posterior presentation? As you all know, when the spine of the baby is anteriorly, there is convexity of the uterus. So the wall of the abdomen, it appears more convex. But in occipito-posterior, the back of the fetus is lying posteriorly. So the lower abdomen feels more flat in these patients. So these are the cases where you suspect that it can be occipito-posterior. And further, when you do the palpation, you will not be able to feel the back on the side on anteriorly. It will be placed more in the flank. And the next very important thing is that when you are palpating the fetal head, it will be deflexed head. So these are the few things which will be there in the examination finding. And when you auscultate, the fetal heart is located in the flank of the mother. But at times you can hear the fetal heart through the chest of the baby. So it will be placed anteriorly also. So most of the times you'll be struggling to locate the fetal heart. At times you'll hear it anteriorly, then in the flank. So it is not very distinctly heard because this
we generally auscultate the fetal heart through the fetal bag, and that is placed posteriorly. So these are the common things which you'll find. And when you do a per vaginum examination, so in early labor, because of the deflex head generally engages late in labor. So the cervix may be loose hanging, the bag of the membrane, it may be, long bag hanging, and at times it is, there is rupture of these membranes because of the head not being properly fitting into with the cervix, not well applied to the cervix. So these are the common things which make you suspect that it is occipito-posterior position. Then definitely final thing is when you can feel the sutures and you can appreciate the fontanelle, that in labor you get to diagnose occipito-posterior position. So now there are a few problems with the occipito-posterior position. We don't call it as malpresentation, we call it as malposition, because in 90% of the cases, the mechanism of the labor is such that you can have delivery in occipito-anterior position. Because only the 10% of the patients where either there will be arrest of labor or maybe the occiput will rotate posteriorly and there will be delivery as face to face. So whenever you are asked to demonstrate a mechanism of labor, so it is always a good practice to follow few points. So first of all is that if you have been asked to demonstrate mechanism of labor in a particular position, so you decide, unless the position is specified, that which position you are demonstrating labor. Like in occipito anterior, if you have been asked to demonstrate mechanism of labor in demonstrate in normal labor, so you have a choice between left occipito anterior or left occipito transverse, unless it is specified. So just because the otherwise the main steps of the mechanism of labor are same with occipito anterior and posterior, and this is the first class, so I'll quickly demonstrate the mechanism of labor in occipito anterior, and then I'll go on to what is the difference in the occipito posterior. So this is the pelvis and the skull which I am holding, and as you can see, this is the occiput and this is the
1 minute, Dr. Rekha. I would like to request our admin to kindly spotlight on Professor Rekha Bharti, because everyone wants to see her and the pelvis. Yes.
Yes,
That's
sir.
the right view. Yes. Thank you so much. Thank you.
So is it okay now?
Absolutely okay. Go ahead, please.
So this is the occiput and this is the sinciput, and you can see this is the lambda, the posterior fontanelle, and this is the bregma, the anterior fontanelle. Okay, so when we demonstrate mechanism of labor in occipito anterior position, suppose I choose left occipito anterior, so I'll say that I'm going to demonstrate mechanism of labor in left occipito anterior position, and this position, the anteroposterior diameter of the fetal skull is either suboccipito-bregmatic or occipito, because we don't go on to the suboccipito-bregmatic straight away, because it is the diameter of the bell flex head, and the one of the movement that we are going to describe is of the flexion. So we say it is either suboccipito-frontal or it is occipito-frontal. So suboccipito-frontal is 10 centimeter and occipito-frontal is 11.5 centimeter. So either of these diameters will enter the pelvis in the right oblique diameter of the maternal pelvis. Okay, so with good uterine contraction and there is descent of the head and there is flexion of the head, the maximum transverse diameter of the skull, which is the biparietal diameter, it enters the brim and there is engagement of the head. With further descent of the head and flexion, the occiput touches the pelvic floor. And when you say occiput touches the pelvic floor, these are the ischial spines. So you should be at this level, because you all know the pelvic floor is at the level of the ischial spines. And then what will happen? There will be a movement of 1/8 of circle and it will bring the occiput anteriorly. So previously the diameter, AP diameter of the fetal skull was in the right oblique diameter, and with the internal rotation, it rotates anteriorly. So now why there is internal rotation also we describe, because at the level of the pelvic floor muscle, when the occiput touches here, there is elastic recoil of the muscles which bring the occiput anteriorly behind the symphysis pubis. Now at this time, the shoulders were entering the brim in the left oblique diameter of maternal pelvis. So there is a torsion of 1/8 of circle at the fetal neck. With further descent, the occiput hinges below the symphysis pubis and there is crowning. So what is crowning? When the biparietal transverse diameter of the skull, it reaches the pelvic outlet, 4 centimeter of the fetal skull is visible without separating the labia, and the head does not recede back even after the contraction. The next movement is of the extension, when the head extends and there is delivery of the vertex, brow, and the face and mentum. So after this, the torsion of the neck which was there, that is relieved and the head rotates by 1/8 of circle. So this movement is opposite to the movement of the internal rotation. So in occipito anterior, this was the internal rotation. So the restitution will be like this. So the head will go back to the occiput, will go back towards the left side from where it was originally lying in the pelvis. Now, next movement is actually of the movement of the shoulder. When the shoulders, which were in the left oblique diameter, they rotate and they come to lie in the anteroposterior diameter. This occiput further rotates towards the left thigh of the mother, and this is called as external rotation. Okay, so after that, there is delivery of the shoulders that I'll demonstrate in occipito-posterior also. So basically, why I told you that this is the mechanism of labor when there is, the position is occipito-anterior. So if I talk about now the occipito-posterior position, which is actually the topic for today. So the most common presentation is right occipito-posterior. So in right occipito-posterior, this occiput will be on the right side posteriorly. So it will be the common engagements, they all take place in the right oblique diameter. So the anteroposterior diameter, and here the head is deflexed because the back of the mother and the baby are on the same side. So in occipito-posterior presentation, there is slight deflection of the head. So the diameter which present, the anteroposterior diameter which will enter the brim would be the occipito-frontal diameter, which is around 11.5 centimeters. So this diameter enters in the right oblique diameter of maternal pelvis, which is 12 centimeters. Okay, so with gradual descent due to the uterine contraction, there is descent and increasing flexion. And now the biparietal diameter passes the brim, so the engagement of the head takes place. And with further descent and flexion, the occiput touches the pelvic floor first. Now this occiput rotates by 3/8 of circle. So the occiput which was in the right oblique diameter, this comes to lie behind the symphysis pubis in the AP diameter. The shoulders, they cannot, neck cannot sustain so much of torsion. So as the head rotates anteriorly, the shoulders from the left oblique diameter, they also come in the right oblique diameter. So this is one difference, that the rotation is by 3/8 of circle. And as the head is rotating, the shoulders rotate by 2/8 of circle. So the shoulders are also now in the right oblique diameter. So in occipito-posterior, the head also entered the brim in the head entered the brim in the right oblique, and the shoulders are also now entering the brim in the right oblique diameter. So there is net torsion of 1/8 of circle at the fetal neck. So after this, the delivery is almost same as it was in the occipito anterior. The occiput will hinge below the symphysis pubis. There will be crowning, and then there will be delivery of head by extension, and then there will be restitution, which will be followed by external rotation. So I just demonstrate it with the doll also once again, so that you can understand the movement of the shoulders which are occurring here. So in occipito-posterior, this is the position where I'm holding the baby. So occiput is posteriorly. So it is entering the brim in the right oblique diameter. As the head descends, there is flexion. and the occiput touches the pelvic floor and it rotates by 3/8 of circle. So now you see, if the shoulders had to enter in this with this position of the occiput, they would have entered brim in the right oblique diameter. But when the head rotates by 3/8 of circle, the shoulders also rotate by 2/8 of circle. So now the shoulders are also in the right oblique diameter of the maternal pelvis, and then with the baby further descending, there will be crowning and delivery of the head by extension. Then there will be restitution. So restitution is in the opposite direction and it is by 1/8 of circle only. With further descent, anterior shoulder hinges below the symphysis pubis. With the lateral flexion, posterior shoulder and the arm is delivered. This is followed by release of anterior arm and rest of the body by lateral flexion. So this is one of the favorable outcomes of occipito-posterior presentation. So if it is an adequate gynecoid pelvis and the baby is not too big, there is this long anterior rotation and delivery as occipito-anterior. So now if there are some unfavorable outcomes of occipito-posterior, so those outcomes are generally seen in android kind of pelvis when the pelvis is not adequate. So what will happen when the head is descending? Both sinciput and occiput, if they touch the pelvic floor at the same time, there will be no rotation. So if there is no rotation, there is arrest of labor in the right occipito-posterior position, or there could be short anterior rotation and arrest in the transverse position. At times, we also call it as deep transverse arrest. So it can either be arrest of labor in the occipito-transverse position or deep transverse arrest. For deep transverse arrest, we actually have a specific definition that when the cervix is fully dilated and the sutures, the sagittal sutures, it plays in the transverse diameter of the maternal pelvis, head at 0 station, in primi for 1 hour and in multi for half hour, with good uterine contraction. If there is no further descent of labor and progress of labor, it is called as deep transverse arrest. But nowadays, because we do not define the arrest by this 1 hour and half an hour, generally, and it may not be at 0 station also. So wherever there is arrest of labor with the sutures in the transverse position and there is no further progress of labor, it is called as arrest in occipito-transverse position. So this is another situation. Then there could be short posterior rotation. Now, why would there be posterior rotation? If the sinciput of the baby, it touches the pelvic floor in a deflexed head and it rotates posteriorly by 1/8 of circle. So this will cause either arrest in the direct occipito-posterior position, or there will be delivery by face to pubes method. So now what is this face to pubes? And this will basically be happening in anthropoid kind of a pelvis. No, so now in anthropoid pelvis, you know that the posterior segment of the pelvis is broader than the anterior segment. In gynecoid, it is more or less round, but in the anthropoid pelvis, the posterior segment is wider. So this wider occiput is placed more posteriorly. So that kind of pelvis favors delivery in the occipito-posterior position, and this is called as face to pubes delivery. Now, how it happens, I'll just demonstrate that. So the same thing, the occipito-frontal diameter of the fetal skull, it enters the brim in the right oblique diameter of the maternal pelvis, which is 12 centimeters, and there is descent of head without flexion. Okay, so this is deflex head that's going in, and the sinciput touches the pelvic floor and rotates anteriorly by 1/8 of circle. So when the sinciput has rotated anteriorly by 1/8 of circle, the occiput goes posteriorly. Now in this position, the shoulders of the baby will be in the left oblique diameter of the maternal pelvis, and there will be torsion of the neck by 1/8 of circle. With further descent of the head, the root of the nose, so this is the root of the nose, it hinges below the symphysis pubis, and that movement of flexion which did not take place initially, so there will be this after hinging of the root of the nose, there will be flexion first and the vertex and the occiput will deliver, and then there will be extension, the face and the mentum would be delivered. Now, this problem with this kind of a delivery is that this broader occiput is going to stretch the perineum. So when the broader occiput stretches the perineum, there are chances of complete perineal tears. So perineal tears are more common, and they may even extend into the either into the anal canal, or this they may involve the sphincter. So type 3 or 4 perineal tear could be there. So this is one this is one condition where we prefer giving elective episiotomy. So nowadays we don't actually practice elective episiotomy. We give selective episiotomy, but this is one condition where if we know that it is occipito-posterior, that is why it is important to know the position of the head. You have to give episiotomy in these patients. All patients would receive episiotomy. Okay, now after the delivery of the head, now there is restitution. So occiput goes towards the right thigh of the mother. Then as the shoulders rotate, there will be external rotation and rest of the delivery as in occipito anterior. So I'll just show you with the dummy also how this is happening. So when the head enters the brim in the right occipito posterior position, and there is descent and no flexion, so that the sinciput touches the pelvic floor first, and there is rotation by 1/8 of circle, and the occiput rotates posteriorly, and the sinciput is anterior. There is torsion at the neck of 1/8 of circle, with shoulders entering the pelvis in the left oblique diameter. With further descent, the root of the nose hinges below the symphysis pubis. With movement of flexion, the vertex and the occiput is born. With extension, face and mentum is born. Then there is restitution, and this is followed by external rotation, which is because of the rotation of the shoulders. And shoulders from the left oblique diameter of maternal pelvis, they come to lie in the AP diameter. Then with further descent, anterior shoulder hinges below the symphysis pubis. With lateral flexion, there is delivery of the posterior shoulder and the posterior arm. This is followed by release of the anterior arm and rest of the body by lateral flexion. So this is what is called as face to pubes delivery. Now, if you are applying forceps in this kind of for this kind of delivery, then it is very important that you should first flex the head and then only you extend the head. So this is what is to be remembered in occipito-posterior position. Okay. So this was about all kind of deliveries that are possible with occipito-posterior position. The only thing is, if the delivery is in occipito-posterior position, you have to give a liberal episiotomy so that you do not have perineal tear extending into the rectal mucosa or the sphincter. So that's all from my side, sir. So anything anyone wants to ask, I can answer.
Thank you, Professor Rekha Bharti. Wonderful and very, very lucid presentation on occipito-posterior position vis-a-vis occipito-anterior. And I believe the students will be clearly aware of the differences between what happens when the occiput is placed posteriorly versus anteriorly. Thank you very much for that. Just one or two points I'd like to make here, in addition to whatever you have said. In the examination, you have mentioned about the difficulty in locating the fetal heart sound for obvious reasons, because the fetal spine is at the back, and difficulty in transmission of the fetal heart sound rather from the fetus. Another observation that students should note is whether there is a suprapubic flattening in the abdomen. That means instead of the bulge that we normally see in the occipito-anterior position, there is usually a normal, a flat type of abdomen in the suprapubic region. That is one point the students should, note for. And whenever they see that, the suspicion should be raised about the position of the occiput in the fetus. Secondly, while the teaching goes on how to hold the fetal head, we usually teach that the first thing is always put the index finger of the right hand into the foramen magnum. That will clearly sort out any difficulties in placing the head Otherwise, they will make mistakes on the fetal neck, and the placement of the fetal head will cause difficulties in rotation of the fetal head and shoulder, etc., etc. The third point I'd like to mention is that you talked about the long internal rotation, that is 3/8 of a circle, and that normally happens in a favorable circumstances. But we have to remember that this is not the type of pelvis which yields the occipitoposterior. Occipitoposterior is a result of a different type of pelvis, either an anthropoid or android type of pelvis. So in spite of that, the favorable outcome happens in 90% of cases. So I think wait and watch is the policy should be adopted in cases where they diagnose it properly. Antenatal diagnosis may be difficult. And another important point is the counseling of the woman during labor and also the relatives of the patient, because it takes 3 times the time of the internal rotation and there is a delayed engagement, etc. So this thing should be counseled with the all the waiting relatives outside the labor room and also the mother, and we always encourage her. Thank you very much. It was an
And
excellent
one
presentation.
more point I would just like to add also, because the occiput posteriorly, it presses on the rectum. So that leads to premature bearing down efforts also. So these patients should receive good analgesics. So this is also one thing which we have to take care of.
Okay.
Yes, Dr. Rekha, yes, it is very important to highlight the clinical part also. Means first we start with the how to identify occipital posterior in a pregnant lady at term or whenever she comes in labor. So clinical examination is very important, and all our students should learn how to identify. There are few features which can be there. Then, as you told rightly, there are few characteristics in labor. End of first stage or early second stage, you may find those excessive back pressure without cervical dilatation, and patient might be very severe, having backache, and these type of things will really identify. And obviously prolonged labor and delayed in engagement of the head and all these parts will be there. So it is very important to identify occipital posterior at an early stage. So besides this, then the second part comes is the how to manage these, because see mechanism, all are these things are theory. We are not able to see what is happening inside. So it is better to identify how to identify, that is more important, and then how to manage this situation. So from the beginning, what all can be done from outside, basically, in the layman terms, what can be done from the outside. So these type of things which should be there, and the changes in the practice. These are all important components when we talk of theory, because earlier we have learned in our books about manual rotation of it is there. We can do half a hand rotation, full hand rotation, and all those type of activities. But those nowadays are not done routinely, and those are not mentioned in the books also. So these type of things students should be aware of, and we should be providing more information on all these things. Dr. Ashish, yes or no?
Yes, sir. Thank you very much for raising
Can I
this.
just add something, Dr. Ashok? Dr. Ashish, can I
Yes,
just add something?
yes, Dr.
Yeah.
Shilamani, yes.
So, as a clinical examination, we are telling, so first I would like to tell all the postgraduates that when you do pervaginal examination for a normal position, try to see where is the sagittal suture. See, that is how you learn, and you know it is anterior. That is, that the posterior fontanelle is in the anterior compartment. What happens in occipitoposterior, that the anterior fontanelle is easily felt on pervaginal examination, which does not happen in anterior position. So the moment you feel that you are able to palpate the anterior fontanelle easily, you have to suspect a malposition. So first you have to know the normal position so that it will be easy. And as everybody has told, diagnosis is important, because all of us, we know that the management differs. It takes more time, dilatation as well as progress, and everything is deliberated. So do the pervaginal examination, and when the patient is in active labor, and try to feel the sagittal suture.
Thank you, Dr. Sheila, for those inputs. Just one way of why Dr. Ashok Kumar, myself, and Dr. Rekha also, they all insisted on the early diagnosis is that in late labor, when it eventually becomes prolonged labor, the PV examination findings may be difficult for a student, because the caput and molding and all these things come, and it may not be so easy to palpate the anterior fontanelle or the sagittal
No,
suture.
no, not in late labor.
Yeah.
But at least, if they know that how is the normal sagittal suture placed normally.
Yeah,
So they
that
can.
is, in the normal labor, it's okay. That is highly recommended. And I think the early suspicion or that this case could be the occipital posterior, it should be raised in the mind of the PGs. That is what we want to, because later on it becomes difficult. And they always come out with the findings that some soft part is presenting. I can't identify what it is. So I think that early diagnosis is very, very crucial, and more clinical findings should be there in suspecting or identifying where the occiput is. I think they are very, very useful in management of late labor. That's what we wanted to say. That's it.
Yes, Dr. Palaniappan, yes.
Thank you, Dr. Ashish, Dr. Ashok, Dr. Sheila. In the late stage, if you want to diagnose, I think you can use the aid of ultrasound, intrapartum ultrasound, and you'll be able to feel occiput very easily. You'll be able to see in the phonics, and so you'll be able to say where the occiput is. If at all you've missed diagnosis in late and she's not progressing, please try to use the intrapartum ultrasound in the labor room.
I hope eventually when the ultrasound is becoming more and more popular in the second stage of labor or late labor, it becomes more useful in the diagnosis. But as of now, in most of the centers that I've visited, they do not have the facility of labor room ultrasound, which is less than optimal, I'll say, for the time being. But ultrasound is coming in a bigger way in diagnosis of presentation and position in late labor. Thank you very much, Dr.
No, that is what that is what I emphasize, that the student should be aware of the changes in the practices now. Because now in the second stage, we are not using manual methods. Now ultrasound has come up. Rather, more inclination is towards the operative delivery. We are not using forceps also, because we can deliver face to pubis, but how many we are delivering at the moment, we should know. So these are the things which are changing also. So then the occipital posterior, therefore,
we can take this later on forward with the role of ultrasound gradually evolving, and we're still in the lookout of a good labor care with the help of an ultrasound, which I believe will mature with the days to come, I think. So let us be optimistic about that, and with that we'll keep that in there, and we'll go to the next session.
I think we can have one session. We can have one session on ultrasound in labor later. Okay.
Yeah.
That is for the post.
One more point I would like to add, which is generally written in the books, is for the PGs to know that one was that these patients should be well hydrated, but that goes true for all the patients who are in labor. And second thing is that previously we used to say that membranes should be preserved till long, but nowadays we are not doing practice of early ARM in all the patients. So that was basically so that we retain for the long rotation to take place. So I didn't mention because these are the general practices these days for all the patients. Even in occipito anterior, we are not doing early ARM, not favoring early ARM these days. So these two are the things which are generally mentioned in the book. And one very important thing in labor, as we said, with capote and molding, it is very difficult to make out which is anterior and posterior fontanelle. So what we teach our resident is that from the fontanelle you try to trace the sutures. If you can trace 4 sutures, it is anterior fontanelle. If you trace 3 sutures, that is posterior fontanelle. Because in labor rooms, generally this practice, when ultrasounds they cannot do for all patients, we tell them, and it is mainly important when you are going to apply forceps or vacuum, that you should know the exact position of the fetal head. And one previously, as we used to say, that the pinna, the unfolded pinna of the baby points towards the occiput. So these are few points which the PGs should know. Like these come from the old teaching that they should be.
Yes, Dr. Rekha, but
so thank you. Thank you.
That point because much before that they will advise a C-section. Anyhow.
Okay. So before Dr. Palaniappan has a comment, then we invite Dr. Manjupuri to say something.
Yeah, Manjupuri has raised her hand. Yes.
Dr. Palaniappan, you want to add something?
No. Okay. Dr. Manjupuri.
Dr. Manju.
Yeah, good morning. So basically, I think Rekha has made that point that you place your finger on the sagittal suture and sweep your other finger all around. So if there are 3 sutures coming there, then it is anterior fontanella. And if 2 more sutures you encounter, then it is posterior fontanella. That is a very important way of differentiating between the two. Thank you. Yeah.
Thank you so much. We will now move to the next session. I think Hafiz, please start the next session. Thank you so much
sir.
to the faculty and the interaction that followed, which is very useful for the students. Thank you.
Thank you, sir. Thank you so
Thank
much.
you so much, Professor Rekha Bharti Madam, and all the eminent faculties for your comments. So now we'll move to our second session, that is case discussion. This is one of the most consistent program all throughout. So this month we have students from KEM Hospital and Seth GS Medical College, Mumbai, and they are going to have a presentation on ovarian endometrioma. Now we have the students, Dr. Manasha KK and Dr. Nikhil Arjun Bharat, both are third year students, and they have been guided by their HOD faculties, that is Professor Padmaja Y. Samant. Madam, she is Professor and Head, KEM Hospital and Seth GS Medical College, and Dr. Himangi Sudhakar Varke, actually she is the additional professor at KEM Hospital, Mumbai. Now we have eminent faculties, like we have consistently Dr. Ashish Mukhopadhyay sir, she is Saris Principal and Professor at CSS College of OBGYN and Child at Kolkata. We have Professor B.S. Jodha, sir is Principal and Senior Professor at SN Medical College, Jodhpur. We have another Professor N. Palaniappan, sir is Professor and Head at Sri Ramchandra Medical College, Chennai, Tamil Nadu. We have Dr. Pratibha Rai, Madam is Professor and former HOD at SNMMCH Dhanbad. And Dr. S.P. Jai, we have Professor Dr. S.P. Jaiswar, Madam. Madam has some emergencies, but she if she gets time, Madam will join. AK and Dr. Nikhil Arjun Bharat to share its screen, introduce yourself and start your presentation. And at the same time, I'd like to request all the faculties to kindly take over and take the case of the students. Over to you, all of you, students and faculties.
Students, are you ready with the presentation?
Manasa and Nikhil.
Kindly open the presentation and then share screen.
On the faculty. Thank you, Dr. Bhaskar Pal and Dr. Sheila for offering us opportunity to this case presentation. And thank you to the faculty for being present here. We're really grateful for the opportunity. And now I'll just share my screen.
Please make it full screen. Nikhil. Yeah.
Dr. Nikhil Bharat, third year PG resident in St. J.S. Medical College, KEM Hospital.
Good afternoon, all the faculty. Myself, Dr. Manasa KK, third year junior resident from St. J.S. Medical College in KEM Hospital.
So we will start the clinical case presentation, the history part presented by Dr. Mansa. I'll move with examination.
I'll start with the history of the case. Today, we are presenting a case of Mrs. P, who's a 34 years, who is married since 3 years, and she's a Nalli Gravda, working as a software engineer. She's a resident of Dadar. She presented to our OPD on 7th of January 2026. She came with a chief complaint of pain during menstruation since last 6 years, where it was increased in its last 2 years. She also had pain during sexual intercourse. It progressively present over the past 2 years. As per her discussion, the pain was such that initially it was very mild, where it was getting controlled with the use of NSAIDs, where the use of analgesics, where she has given history that she has used tablet bifenamic acid for the same since 6 years. She has been using it on and off. And the pain was crampy more in the lower abdomen, and it usually started 1 to 2 days before the menses. It peaks during the first and second day of menses, and it subsequently regresses over the next 3-4 days. But however, the severity of the pain has increased since last 2 years, and it has become to such an extent that it is not getting controlled with the use of analgesics, and she has to get absenteeism from work also because of the pain. Along with this, she also complained of pain during sexual intercourse since last 2 years, but the pain was more on the deep penetration, which was limiting her frequency of sexual intercourse. Even before she used to, the couple used to have 3 to 4, the sexual intercourse frequency was 3 to 4 times per week, but now it has reduced to an amount of 1 to 2 sexual intercourse per month since last 1 year. She also gave complaint of painful defecation during periods, where she has experienced it in the past few months. But there was no history of bleeding per rectum. There was no history of bleeding during urination. There was no pain during urination. She did not have any altered bowel or bladder habits. She did not give any history of fever, weight loss, or loss of appetite. Coming to the past history, she did not have any surgeries in the past. She did not have a history of tuberculosis, diabetes mellitus, hypertension, thyroid disorder, asthma, heart attack in the past. She does not have any allergy to food, any allergy to any. She did give history of medications in the past, which is of analgesics. Other than that, she did not have any history of chronic medications. Coming to the personal history, she consumes a mixed diet. Sleep and appetite is normal. Does not have any history of does not have any history of addictions like smoking, alcoholism, or tobacco chewing. She did not give any history of weight loss. Her bowel, as I said earlier, bowel and bladder habits are regular, but she reports high work stress in her workplace. Coming to the menstrual history, all throughout she has attained her menarche at 12 years of age, but all throughout she has had regular cycles where she used to get periods once in 28 to 30 days. Periods were regular. The flow was for usually she gets the flow for 5 to 6 days, soaking 2 to 3 pads per day, and it was associated with pain. The pain is there pain is more during the last six years, where it has increased more in intensity since the last 2 years, as I explained it in the initial slides. The last menstrual period, when she has come to us, her last menstrual period was 1st of January 2026. Coming to the marital and sexual history, she is married since 3 years, cohabiting non-consanguineous marriage, cohabiting with her husband. The couple is not using any method of contraception, where, as I told earlier, the frequency of intercourse has reduced because of the pain, which was 3 to 4 per week in the initial times, where since the last 1 year it has reduced to 1 to 2 times per month. The couple is anxious to conceive. In her family, she does not give any history of ovarian, endometrial, or breast cancer. Did not give any history of diabetes mellitus, hypertension, cardiac disorder, thyroid disorder, asthma, or tuberculosis in the family. Other examination will be done by Dr. Nick.
So coming to general physical examination, our patient was moderately built. Her height was 154 centimeter, weight was 50 kilograms, and BMI was 21 kg per square meter. Mild pallor was present. There was no lymphadenopathy found. Breasts were normal, and there was no any obvious swelling in the thyroid gland, which was noted. She was afebrile at presentation. Pulse was 84 beats per minute regular. BP was 112 by 74 millimeters of mercury. Respiratory rate of 14 cycles per minute. The cardiovascular respiratory systems were within normal limits. No abnormality was detected, and no abnormality detected in the CNS examination. Coming for abdomen examination, the abdomen appeared scaphoid. The umbilicus was central and inverted. No lump or mass was directly seen. No scars were seen. On palpation, the abdomen was soft. There was no tenderness or guarding noted. No palpable mass on per abdomen examination. Coming to local examination, the vulva and the perineum appeared normal with no local lesions seen. On per speculum examination, cervix appeared normal and pinpoint. And on introduction of speculum in the posterior fornix, tenderness was noted. There was no evidence of any discharge or lesions. On bimanual examination, the uterus was retroverted, normal in size, firm, with restricted mobility, and was not tender. Additionally, a cystic mass of approximately 5 centimeter diameter was felt in the right fornix, not felt separately from the uterus, and it was tender as well. On PV examination, cervical motion tenderness was noted, and in posterior fornix, a nodularity was felt along with tenderness. So, in summary, our case is of a 34 years nulli gravida presenting with progressive dysmenorrhea and dyspareunia since 2 years and anxious to conceive, with examination findings also suggestive of retroverted uterus with restricted mobility, a mass of approx diameter 5 centimeter, with cervical motion tenderness and tender nodularity in the posterior fornix. On the basis of this, the provisional diagnosis that we have is of nulli gravida with pelvic endometriosis. And the differential diagnosis that can be considered is an endometrioma with pelvic endometriosis, can be a pelvic inflammatory disease, genital tuberculosis, or a fibroid uterus. There is a possibility of a subserosal or a broad ligament fibroid.
Yes, Nikhil, how do you want to differentiate between your diagnosis?
So in our case,
You
the
put 4
diagnosis
DDs,
seems to
isn't
be...
it?
Yes.
Dr. Palaniappan, before you go into that question, I'll just try to put forward few of the questions that will be raised in the history part and also in the examination part. Could you go back to the history part, please? Chief complaint slide I want to see.
Yes, sir.
You see, you have written chief complaints, pain during menstruation for 6 years, increased in intensity over last 2 years, correct?
Yes, sir.
Okay. Actually, what happens, chief complaints, whenever we say the progress of the chief complaint, progress of the pain, etc., we keep it reserved for the history of present illness. So it's enough to say that she's having pain during menstruation for 6 years. That will indicate the extent of the disease, length and depth of the disease, etc. That it has increased in intensity over last 2 years, that will be discussed in the history of present illness. Okay. That means evaluation of the chief complaint. Okay. Secondly, although you have said that they are anxious to conceive, it is not included in the chief complaint. That means they haven't complained about the inability to conceive, whatever reason, they haven't mentioned that. In these cases, normally what happens, she's how much, 31 years, no? Married for 4 years, six how many years?
34 years.
34 years.
34 years.
30.
And married for?
3 years, sir.
3 years, okay. It is usually...
3 years.
3 years. It is usually the chief complaints come there. Although they know for certain that it is because of the infrequent, uniting with the husband and, lack of sexual, drive, etc., because of pain. But still it should come in the chief complaint. Okay. In case she doesn't complain about it, then you should ask a leading question. There are ways and means to take out chief complaint, but it should be coming from the patient's mouth or the couple's mouth. Okay. Now, in the come to the provisional diagnosis part, with the kind of examination findings that you have given in the pelvic examination, you have clearly found an adnexal mass, correct? Show me the PV examination part. You have mentioned about a mass. You have mentioned approximate size also. So I think, yes, cystic mass of approximately 5 centimeter diameter, if you have found it clearly, then there are certain elaborations of this mass necessary in this thing, like for instance, whether the mass is separate from the uterus, whether it is, when all these details are there, Roop sign is there or not, and the mass is that define the mass, like size you have mentioned, but the consistency of the mass, tenderness, movability, etc., these should be given. Having said that, this mass, once you have found in the bimanual examination, it should come into your provisional diagnosis. You should not come in your differential diagnosis. Is it not?
Yes, sir.
So differential diagnosis, go to the differential diagnosis, which was originally question of Dr. N. Palaniappan. Yes. Endometrioma with pelvic endometriosis, I think this should come in the provisional diagnosis. Okay. And the rest of the 3, with that, I would like to add adenomyosis. Okay. And
Yes.
fibroid uterus,
Yes.
you have mentioned. Oh, that is obvious. Yes. Dr. Palaniappan, you may continue from this point onwards. My points are over.
What is your differential diagnosis is what I asked.
Thank you, sir.
How would you differentiate? You have put 4 DDs.
So we
Each
have
one of
given
them,
4
how would you
differential
want?
diagnosis. The first one, yes,
First, move to the provisional diagnosis,
sir,
right?
we have to consider factors from both history part and from the examination part. Examination part as well. History, the patient has complained of dysmenorrhea and dyspareunia, which could be because of a pelvic inflammatory disease or could be because of an endometrioma or the endometriosis. However, the patient did not give any history of fever or any history of frequent usage of antibiotics, or if there was no history of TB in the past. Family history also did not show any history of TB or infections in the family. So it is less likely that she is suffering from a pelvic inflammatory disease from a history point of view. And from the history and from the examination, the patient had an adnexal mass which was on the right side. Usually, pelvic inflammatory disease can have a unilateral or maybe have a bilateral adnexal mass, and the mass was tender, which could be a possibility in both endometrioma and pelvic inflammatory disease. But the local per speculum examination, there was no white discharge which was seen. There was no warmth which was felt, which could probably rule out the cause of rule out pelvic inflammatory disease.
Additionally, the pain that the patient complained of was more during the menses, and it was a crampy nature of pain. Whereas in the pelvic inflammatory disease, we might see a more diffuse kind of abdominal pain. That is also one more factor that is pointing.
But Nikhil, pain is a very subjective symptom, and you cannot put much reliance upon the type of pain differentiating that. You may suspect, okay, that's all right. But pain is a very subjective symptom. I mean, same pain will be crampy in one person, and in another person, you will find it, licking or maybe tolerable or maybe something like that. Okay. So that's okay. All of the points are taken. And what about adenomyosis as a differential diagnosis? What do you say about that?
But they said uterus is normal in size, isn't it, Nikhil? You should have defended
In
there.
the bimanual examination, the uterus is found to be normal size, sir. That is less likely to suggest adenomyosis, as it is a globular size enlargement of the uterus generally seen as a characteristic. And along with that, she is complaining of dysmenorrhea, which is of a more gradual, which is more of a gradual onset, whereas in adenomyosis you'll find dysmenorrhea persisting throughout the cycle
so that
also.
way,
And
clinically, yes, that way, clinically, maybe, in adenomyosis is a second thought. Of course, we will depend on other findings like from investigations, and when the examiner crosses you further, you will go on that. But what about twisted ovarian tumor or twisted ovarian cyst? Not necessarily
a twisted ovarian cyst.
Yes.
Sorry, sir. So twisted ovarian cyst is more likely to present with more acute symptoms and alternating symptoms, where she might also have sudden exacerbations of abdominal pain, along with possible episodes of vomiting as well, which the patient has not complained about. And patient has not complained of exacerbations of the abdominal pain. It has been more of progressive and constant and more during the menses. Additionally, the mass appears on examination to be fixed, adhered to the uterus, and uterus is less mobile. So the chances, on the basis of this, the chances of visiting of an ovarian cyst seems to be slightly less likely.
You should defend saying that the pulse
Also,
rate is normal.
Pardon?
Pulse rate is normal, isn't it? And a twisted ovarian cyst pulse rate will definitely be high.
Yes, sir. Yes, sir. Her vital parameters could have been different if it is a twisted ovary. She would have had tachycardia or she would have had hypertension.
Are not there. Okay. But then, that twist.
And it also depends on presentation, sir.
No. Whenever there is an adnexal
presentation, she might have a detox.
Oh, correct. Now, whenever there is an adnexal mass, you need to think about all those diseases. Sorry. You need to have a differential diagnosis of all those differential diagnoses of adnexal masses. Okay. So you need to keep that in mind. Okay.
Yes, sir.
And why do you think it's not a subserosal fibroid?
Sir, in cases of subserosal, from our history point of view, if it was a fibroid, she would have given a history. She would have given a history of heavy menstrual bleeding, which she does not have.
Manasa,
And
Manasa, wait,
Dr.
that's a
Palaniappan is saying
subserosal fibroid. A
subserosal
subserosal
fibroid.
fibroid
okay,
cannot have heavy
It doesn't
Yes,
cause.
that's not
sorry,
sorry.
might not be present.
Yes,
It can
sir.
cause.
But
It
in
can cause.
and from coming to the examination part, subserosal fibroid wouldn't have had a tenderness unless and until it has had a degeneration.
Degeneration is
And
very
so the
common.
mass which we felt on bimanual was more of a cystic.
Okay.
Sir?
Cystic degeneration can cause pain, you know. Any fibroid can cause degeneration and pain. And that will be continuous, dull, aching, vague type of pain over last period of 6 years or 2 years or whatever it may be. I think these are all, you know, these are all differential. Why you should include in this differential diagnosis, because it denotes to the examiner that you are thinking about this case, isn't it? So always you should be involved with
Yes.
the case and find out what are the possibilities. Possibilities may be ruled out, possibilities may be confirmed, reconfirmed, etc. by investigation later on. But these things should come in your mind. That's what the examiner wants. Okay.
But now,
Yes.
how do you
Yes.
want to diagnose? How do you want to confirm your diagnosis now? How do you want to confirm your diagnosis?
Yes, sir. Initially, we'll go on with the laboratory investigations, including the blood investigations and the imaging modalities. In the blood investigation, I would do a routine workup, like the complete blood count will be seen, because I wanted to rule out pelvic inflammatory disease. I want to see if her WBC count is within normal limit or not. And then for a definitive diagnosis, we would like to go with an imaging modality. We will first do a transvaginal sonography, in which we will see for the uterus, size of the uterus, and the adnexal lesion, the size and character of the adnexal lesion. And we will also see for any nodularity. If it was a case of endometriosis or a pelvic inflammatory disease, there could have been nodularities which has been present in the peritoneum, including over the uterosacral ligaments or over the rectovaginal septum, or throughout the peritoneum as well.
Additionally, the adnexal mass, we would get a clarity on the transvaginal ultrasound. In case of an endometrioma, it would have the characteristic ground glass appearance of the cyst with a homogeneous internal echoes with it. So that would point strongly towards endometrioma.
Okay,
Perfect.
so for that you need for diagnosis you need an ultrasound, and I've also specified it to be a transvaginal sonography. We agree that there is no doubt about that. Do you think that for the diagnosis you need MRI or CT scan or something like some more advanced imaging investigation in this case, or you are happy with that?
Sir, that would depend on the operator expertise. In case in expert hands, sir, even an ultrasound can provide a lot of clues. But in case the ultrasound is inconclusive, so that might mean that the cyst could not be characterized properly or nodularity could not be properly visualized. So in the presence of our clinical examination findings, if we have found a tender nodularity on the bimanual examination, however, if the ultrasound does not show it, then we might want to proceed.
Okay, Nikhil, I'll put a question.
It will help to
Nikhil,
exactly delineate if there are nodules present. And
okay, Nikhil, hold on. I'll put the question in a different way. What are the indications for MRI in this case? Agreed, there is a ovarian cyst, endometrioma picked up by the ultrasound. I want to get more information on the patient, so I think MRI will give me more information. What more information can the MRI give you?
So the MRI can give us additional information about whether adhesions might be present or not. If there is an obscuring of fat planes, then it might suggest a presence of adhesions, which might affect our future.
Also, if we want to see if there is an involvement of the bowel or the bladder, and MRI would be a better choice than the ultrasound. And to see the extent of the disease, whether it has involved into the rectovaginal septum or if it was involved into the uterosacral ligaments. So to see the peritoneal lesions, MRI would be a better choice than the over the transvaginal ultrasound.
Lower sensitivity for
because even if from our
yes, Manasa, all these eventualities that you have described, I mean, addition with the bowel or omentum, or these are consistent with your case, because she is having a pain since last 6 years, which is aggravated over last 2 years, and additions, they can change their nature and characteristics, and therefore I think these are very important points. And you need to see whether there is any addition with the bowel, etc. and also the character of the cyst, ovarian cyst that you have diagnosed by ultrasound or have diagnosed clinically. So there is enough reason for an MRI to be done, and just in case before, particularly when you are going for an operative management or something like that, at least at that stage. This generates another question. The question is that, taking aside the mode of operation a bit aside, do you want to have a look into the pelvis, like laparoscopy? Is it necessary for this diagnosis, or you need to keep it reserved for diagnosis come management later on? What is your opinion? Or whether you don't want laparoscopy at all?
So this would be based on the shared decision making, and we would have a discussion with the patient and the husband as well. Because the latest ASHRE guidelines mention that diagnostic lab is now no longer the gold standard.
Not for diagnosis.
Diagnosis, yeah. So if in experienced hands, MRI and ultrasound are sufficient to make a management plan. But we can also definitely offer the laparoscopy option of diagnostic lab to the patient. And we can, based on the imaging findings, we can discuss the potential risks and consequences, whether surgical standby might be required or not. And on the basis of this discussion, we can go ahead with the laparoscopy.
So
but of course, it is based on shared decision making.
In this patient, sir, since she is married.
This lady's husband has read from somewhere, the Google University, that and laparoscopy is absolutely essential for this case. And he comes to you. How do you counsel this? That what you have said just now, I agree with them. Completely agreeable observations about X-ray guidelines, about the potential complications of an invasive procedure, everything. But how do you counsel the husband? You need to convince him, because you said it's a shared decision making, isn't it?
Yes.
So how do you counsel? Let's give an example, a sample of a counseling. Say I'm the husband. How do you counsel me? I'm very worried.
Sir, actually, we will talk with both the patient and the husband together, and we'll explain the disease as how the disease has progressed in this particular patient. So based on the examination findings and based on the USG and MRI findings, we'll be explaining them that what the disease she is having and what stage of the disease she is having, and what are the treatment options which are available, or what are the diagnostic options which are available. So basically in this patient...
Manasa, sorry to interrupt. How did you stage the disease now?
I'm saying in future, along with the imaging modalities with USG and MRI findings,
will you be able to
I'll
stage
see
the
how
disease?
extent the lesion has gone into.
Will you
no,
be
no,
able
sir.
to
No,
stage
sir. That will be by laparoscopy only, sir.
Yeah, sir, right.
That is what Dr.
on
Ashish was asking. So would you do a laparoscopy, because you have something called revised American Fertility Society classification, which was available some time back.
Yes.
All of us used to stick it in the labor room.
Sir.
Yes, sir.
Sir,
so now my question is, how do you stage it without a laparoscopy? You spoke about the word staging, isn't it?
Sir, without laparoscopy, we can use the... Yes, sir. Yes, sir. So we can use the engine classification system for this.
That is the deficiency of the revised American
based on the
Society classification. Okay, we had the RAFS classification.
Yes, sir. It will require us laparoscopy.
That is invasive. So that is the deficiency of the system, right? Yes. So that is why we
and
I completely agree with Dr. Palaniappan. You see, all these things have to be explained to the patient party, husband, and because you yourself are saying the shared decision making, you need to reinforce the importance of revised American Society classification, whether it is important or not. Maybe he will go back to Google and ask him this question. Without invasive procedure, you cannot stage the disease. If it comes back to you, it will be advantage to you. So I think being clear everywhere, it does help. You have points. Again, we should not be biased towards any particular, investigative procedure. That's what I wanted to say. Okay, so the examiner will drag you towards that point, like I dragged you towards the point of laparoscopy. The examiners they always have a tendency to do that, and then they will put you in trap. Like Dr. Palaniappan said, how do you stage the disease without laparoscopy? You are going on explaining to the patient's husband that this is the stage of the disease, but you need to mention to him that yes, this diagnosis, this staging is tentative because we haven't done a laparoscopy. Now, if you agree on this, and at the same time, your contribution will be towards the laparoscopy, that we can combine the diagnosis and operative procedure together. I think that will be a good
Yes, sir.
for counseling in this.
Yes, sir.
Okay.
Before that, you want to do something else, Manasa? Some other blood investigation you want to do?
Yes, sir. Before going into the operative part, complete workup of both the patient and the husband, because
That
we
you
want to
said.
see if there is any other cause for their infertility as well.
No.
And
Let's not move. Let's
and
not
we
go
will
to
do a
infertility. Manasa, we will not be able to finish the case if you go on to infertility, tubal factor, male factor. Okay, let us not go into that. Anything else pertaining to endometriosis you want to do? On the blood?
125 level.
Say that. What is the significance of CA 125?
Sir.
Yes, sir. We will do a. Yes, sir. CA 125 is basically a surface antigen which could be increased because of endometriosis, but it is a non-specific thing. It could be increased or a negative CA 125 or a normal CA 125 does not rule out the present absence
but
of.
Would you do? Would you not do?
Additionally, sir, we might want to do.
Would you do or would you not do?
We can offer the patient. It's not a necessary investigation as such, but we can offer the patient.
And also, if you are planning for a surgery, we can do that, sir. That will be the baseline value. And post-surgery, we can even monitor the disease progression with CA 125.
Progress, isn't it? For prognostication, we will do.
Prognosis, yes.
Okay.
We get a baseline value of CA 125.
I have a counterpoint here. You see, you said it is. It is optional, and you are leaving it on the husband. Poor husband. He doesn't know anything about the CA 125. He has to give consent for that. Maybe he has to take his wife to the laboratory for doing this test. But the point is that still I would like to advise the CA 125 in this case. You see, there is some difference between an abnormally elevated value of CA 125 and a moderately elevated CA 125.
Yes, sir.
So that's also important. In a way, it helps in the diagnosis as well. So you can explain this to the husband. He will take his wife to the laboratory with pleasure. Instead of grumbling, he will take his wife to the laboratory with pleasure. That, yeah, abhi kara lo. Do this right now. Okay. So I think that you should advise this. Not all the tumor markers, but CA 125 at least I will definitely recommend, because a kind of a prognostic value and also kind of a baseline negative kind of a diagnosis. Okay. Suppose if this CA 125 is more than 200 or something, then you think about something else, isn't it?
Yes.
Okay. Anything else? Dr. Palaniappan has asked you this question.
So we've on ultrasound and MRI, we've confirmed an endometrioma 5 by 6 centimeters. CA 125 is around 125, 130, and she's got pain. What do you want to do, Nikhil and Manasa? What do you want to do with the case? Nikhil, you are muted. Manasa, unmute yourself.
Sorry, sir, it got disconnected. Just a second.
So what do you want to do? Assuming your diagnosis is correct, you've got an endometrioma 5 centimeters in a nully gravid lady.
Yes, sir.
CA 125 is 125. So what do you want to do?
Sir, we would first, since they are married since 3 years, we will do a basic workup for infertility also, as I said earlier. We will see for her AMH levels, and we will see for her androgen follicular count levels. And after that, we will counsel both the patient and the husband regarding the medical management and the surgical management. Basically, we have to manage her in 3 different categories, where we have to consider the treatment option for the pain, and we have to consider a definitive treatment as well. Either it could be a medical management or it could be a surgical management. For the pain, we will ideally give the symptomatic treatment with NSAIDs or
she's taken all that. No, you said she's taken analgesics, not settling down. That's why she's come to you.
Yes.
Just hold on, Mansa, for a second. Just hold on. You see, here you will understand now the importance of taking fertility concern or subfertility as a primary chief complaints in this patient, which I mentioned earlier. Now, these things will, treatment options will depend on their attitude or approach towards pregnancy, fertility, because you see, they meet rarely. They may not be willing to have a baby also, but they want relief from pain. I know. So things are actually varied types. So along with the fertility is a concern. You said yourself that they're anxious to conceive, but it should come in the chief complaint. So
yes,
but we don't produce that.
Yes.
You ask a question. particularly in like for instance, married for a long time, a bit 30 years or something like that, and you should ask yourself. So these are the cases where to generate a chief complaint, you need to ask some directed questions. Okay, not always, but these are the cases. Okay, now continue. So you are saying that you are going to discuss all these issues with them, considering everything together, the ultrasound finding, the MRI findings, the CA-125 findings, and then take a call about the management. But you must ask the patient what is their priority attention, whether to relieve the pain alone, or whether there there are maybe some difficulties passing urine or stool also, and all these symptoms, and or along with the fertility concern. Now, how does it differentiate between these two? A couple wants fertility in the future, and a couple says whatever happens, you go ahead with the treatment about the pain, even if it slightly impairs the fertility, we don't mind. Then what are the different approaches to these two kinds of patients? Tell us. How will
Sir,
you?
in case she does not want immediate fertility, we will offer her the option for combined oral contraceptive pills for the management of pain, as that is the first line management and the baseline. That is because the basis of endometriosis is that there's an estrogenic dominance in the implants, which is causing them to grow. So, in that way, combined oral contraceptive pills will help with the pain. We will also counsel the patient and husband about this. That basic pathology of your disease is that you have more estrogen. In simple terms, we can explain. And we can explain her about the use of oral contraceptive pills. Additionally, we can also explain that they can be used in a continuous manner as well. And that is one more advantage, that she can continue taking them with regular follow-ups. Just and that will itself act on her pain, and we can assess the pain at follow-ups and then decide accordingly.
Yes, Nikhil, if she's a smoker and she's a little on the obese side, my choice will not be oral contraceptive pill.
Yes, sir. Yes, sir.
Then what will be my choice?
Yes.
I slightly have a more
Sir, we can even do progesterone only pills.
Yeah. Okay. We'll go to that later. But before that, I have a little more basic question. Did you ask about whether the patient had oral contraceptive pill in the report? I didn't see any drugs and contraceptive history in your history sheet.
No. He said no contraceptive.
I have mentioned in one of the slides.
Okay.
No contraceptive. I have mentioned in previous slide that was no history of contraception, no history of chronic drug usage as well.
Yes.
Both I have mentioned.
Okay. So you have.
She did not take any oral contraceptive pills in.
Okay. So now you tell to original question of Dr. Palaniappan. Is progesterone, this thing containing contraceptive, progesterone containing pills are ideal in this case? What about relief of pain? What about the cyclicity of the treatment?
So since she has an adnexal mass, which is of like 5 centimeter, she might need a surgery in future, and excision of the cyst will eventually give her relief of pain. And she is willing for fertility as well. But during surgery also, if there is a risk that if we do a resection of the cyst or excision of the cyst, there could be a possibility that we will even remove the normal ovarian tissues as well. So the fertility could even be affected after surgery also. And this should also be explained to both the patient and the partner beforehand itself. But she might, in this case, might need a surgical excision for a definitive
we'll come to surgery. We are not arguing against your decision for surgery. Now we are going into medical management. My question is, if it is not OCP, what is the progesterone you will want to give? Is it a progesterone only pill? You mean disogestrel is what you're talking about?
Sir, progesterone only pill, norethistone. Medroxyprogestate acetate or norethistone acetate can also be given.
Sir,
as a content.
Sir, Dynogest can be.
So come to the word Dynogest.
Dynogest can also be given, sir.
Hold on for a second. Before coming into this question, you see, what are the things that should go on in your mind? What is the basis of using oral contraceptive pill in these cases? To create an anovulatory cycle, right? So you need to see what is the ability of the contraceptive pill to produce anovulation in this woman. The success rate is important, isn't it? And because on that, the secondary outcome, that is the pain, will depend. Relief of pain will depend. So I think while taking into consideration so many available contraceptive pills in the market, your decision should be based on these: the ability to reduce an ovulation, and indirectly causing relief of pain. Now, I agree with you that this is a temporary method of treatment just to prepare her for the surgery eventually, or maybe that giving us a temporary relief because they're not prepared to have the surgery right now, or they want to Google further. Okay, so I think that that phase is over now. Now come out of the medical management. You want to continue, Dr. Palaniappan, with the medical management because they just mentioned about a dynamic.
Let them mention what are the options available. Dynagist is one option.
Yes.
Anything else available?
Yes, sir. Other option could be a gonadotropin releasing hormone agonist, like injection leuprolide, but that will again cause basically because of the continuous use of the agonist, there will be decrease in LH and FSH, which will cause decrease in estrogen and progesterone as well. But the patient, because of these, the patient may have symptoms of early menopausal like hot flushes.
Additionally, we would also counsel the patient that GnRH agonist is only injectable only. There's no oral option available.
No, Nikhil, before going into that, I'd like another basic question. In the investigation, would you like to have a serum AMH in this woman?
Yeah, she told.
They are anxious.
Yes. I have mentioned it. We will do a serum AMH in trial.
They told Ashish. They told
to get the baseline ovarian.
Okay, fine.
So, leaving alone agonist, would you want to give anything else?
GnRH and
antagonists can also be given. Sir.
What is the
advantage? Like Olix can be tried. The advantage being that it is oral, available in oral formulation, and also one more advantage is it does not have the initial flare.
Okay.
And however, the chronic long-term loss of bone mineral density risk still remains. But
okay.
Nikhil, you are talking about Dynogest. What are the advantages of Dynogest and disadvantages of Dynogest in this case? Tell us. You talked about Dynogest, right? Before going, tell us about the advantages and disadvantages of Dynogest. What is the good point of Dynogest? Bad point of Dynogest? It's an excellent.
Yes, sir. Yes. So Dynogest can be firstly taken orally, and it is easier to be compliant to it. It has lesser side effects. The only side effects that can be seen are breast discomfort. The major side effects can be breast discomfort and headache or abdominal discomfort. Other than that, the side effect profile is relatively less only.
Do you need to have apprehension about the bone mineral density loss or ADVAC therapy with Dynogest?
No, sir, that will not be required.
This will be an advantage with Dynogest, where the bone mineral density.
So now let us assume that you are going to continue with Dynogest for a period of say 3 to 6 months and then review the case. Okay. In case the fertility concern is high, then you should call back after 3 months. In case the fertility concern is not that high, you should call back after 6 months. Okay, fine. Now, what is the next step? Our patient comes back and says that, yes, the pain has reduced, but the dull aching sensation is continuing. And we are now thinking about having a pregnancy because now the husband has started coming closer to me more frequently. What is your option now?
We will do a repeat.
We would also ask for the progress on dyspareunia, sir, as the patient is experiencing, whether that has improved or not.
She said that the husband is coming closer to
ultrasound on
follow-up. That means that the dyspareunia has improved. When the lady says the husband is coming more frequently to me, that means
we would.
Yes. So now they are focusing on the
dyspareunia has improved. Yes, so we will do a repeat sonography to see how the disease are. We would do a repeat sonography to see the prognosis of the disease. We would see how the size of the cyst has increased or decreased, whether the nodules have decreased or not. And if it is of the same size, or if the size has reduced or if the nodules have improved, we would stop with since we would continue with the medical management and we will give.
We'll follow up, sir. Again, 3 monthly follow-up we will be doing. Regarding the infertility, we would again do a serum AMH level to see if there has been any change in the ovarian reserve. And in this case, we will also counsel for planned relations. We might want to do folliculometry also to monitor her follicles. and like the regular infertility workups, we'll tell her for planned relations and follow up for the folliculometry.
So do you expect a reduction in the size of the adnexal mass by this therapy?
Sir, there have been a few cases where the size is reduced, but there have also been cases of poor response. So a clear-cut observation has not yet been found. But in our case, if we find the reduction in the size of the cyst, then we can continue with the medical management with close follow-up. However, if the
Nikhil, 1 minute. If you want to go on that line, is there a better drug other than Dynegest which you can give?
sir, we can try with the elagolix.
Now you have
as
elagolix and
antagonists.
relagolix available, isn't it?
Yeah. Yes.
Yes,
Yes, sir. Yes.
So say that no,
That
we have
we can.
elagolix available easily, which can go on for a year or so, and we have enough trials now. Huge number of patients involved in the trial. The step trials have come in, and then we've had the relagolix coming in. So think in terms of the
Yes.
antagonist. No flare-up, tablets. You can try for 1 year if at all you want.
Yes.
Then you will think
Yes,
in
sir.
terms of. So what Dr. Ashish is asking is, with Dynegest, the size of the cyst may not come down, symptoms may come down. That's all.
Yes, yes, sir.
Size may remain the same. Whereas with your relagolix and elagolix, maybe the size will come down.
Size cannot
Come down by half. Symptoms will improve. Fertility, we don't know. We'll have to check your AMH and other factors.
Yes. Yes. Yes.
Always put in forth, finish off your medical management, and then say, I will try, may not try. Okay. So what are the indications for surgery now? When will you think in terms of surgery?
Yes, now that you have started just elagolix, say, because you haven't talked about elagolix, elagolix you have started. What is the dose that initially you would like to plan for this woman? What is the dose that you usually use in this kind of patients? Have you used elagolix in this kind of patients in the past? Okay, so the results are very encouraging, as Dr. Palaniappan said, and looks like you are not in the habit of practicing elagolix in these particular cases. And also the window, the fertility window expands much more than the Dynegest. So I think that it's a good choice, having given the when the patient accepts the cost and the regularity of treatment and other things associated with this. I think they will continue with that. Now come to the specific question: does it, even elagolix, does it give a foolproof this thing about your forget about foolproof, even half-proof assurance about fertility?
No.
In that case, when do you call upon the couple and sit for the discussion on fertility issues now under surgical management? Okay. So, when do you do that? After 3 months? After 6 months? After 1 year?
Sir, once in every 3 months, we should get the follow-up for this particular patient, this kind of patients. And since the age of the patient is 34 years and age of the husband is 37 years, and they're anxious to conceive. So in this particular case, we might need to consider about the fertility within 3 months.
Yes, we might have to consider surgical management earlier because she's already at the extremes of age. We can say that she's in the elderly gravitar range. We will counsel her about the higher risk of chromosomal abnormalities also in this age group.
Agreed. So after 6 months, you will call her, and what evaluation you will do before surgery?
Yeah, what evaluation will you do?
We might want to do, sir, a repeat MRI, ultrasound and MRI as well, just to delineate the...
Until you're spending on somebody else's money. You tell me now, ultrasound or MRI?
Sir, ultrasound. Initially, we will go for an ultrasound, sir.
I will go for MRI. I will go for
MRI should be done because we have to see for the fat strand. Before the surgery, we have to see what all we have to expect in case of surgery. If there is an addition which is present, if there is a bowel involvement, then we might need to get a surgical standby. We might need to be prepared for the adhesive lysis, and also MRI would be a preferable.
MRI is better. Okay. Don't do ultrasound, waste money. Whatever you get in ultrasound, you get in MRI. But whatever you get in MRI, you won't get in ultrasound.
You won't get it. Yes.
So you can do only MRI. Don't waste on ultrasound.
Yes. Yes.
And I'm sure you will do an AMH before surgery.
Yes.
Yes, sir.
Yes. Okay.
We'll do an AMH and we'll do a husband workup for husband semen analysis also to rule out if there is any other.
Assuming semen is normal and no other male factor, what do you want to do? What surgery would you want to do for this lady?
Okay.
Sir,
Before going into surgery, you call her on the table, call them on the table. But in the meantime, what has happened? The cost of Dynogest plus Elagolix plus MRI plus, this investigations, and they have sold half of their house. The half of the house is remaining now. And now we are going to proceed for laparoscopy, which will sell away the other half of the house, and then go for the fertility treatment. And infertility, for infertility, you have IVF. So I think that you have to need to explain all these things to the couple very well before proceeding to this kind of diagnosis, and also explain to them the plus and minus points of surgery. Okay, you
Yes,
have
sir.
talked about the AMH. Does surgery have any effect on AMH? Does it improve or reduce the AMH? You need to explain that also.
yes.
Okay. So how will you counsel another sample I expect from you? How do you counsel a couple who are standing on the brink of laparoscopy, and you need to convince them about the need of surgical treatment under the circumstances? The patient is relatively quieter now. She's experiencing less pain, and under the effect of Elagolix, she's getting less, bursts of pain less frequently. And of course, they are willing to have one pregnancy. Tell us, how do you counsel this couple?
So we would counsel in such a way that the patient is having, even though her symptoms have improved, the mass which is present or the lesion which is present, they might be still be persistent. So for a definitive, and they are willing for fertility as well. So for a definitive management, surgery would be a better choice. And we still don't know what laparoscopy is the gold standard for diagnosis as well. For to see how extent the disease have gone, or to see how what all lesion she has
Staging.
diagnosed.
Additionally, sir, one more line we would mention is that the severity of pain does not necessarily correlate with severity of endometriosis itself.
Correct.
So the pain relief might not be indicating that the disease has resolved. Then we would also have a look at her AMH and the MRI findings, and accordingly we will counsel her that this is your baseline reserve. MRI is showing, say for example, it is showing some degree of adhesions and the persistence of the cyst. So we will counsel her that since you are in advanced age and we have tried medical therapy, we will want to go ahead with a surgical therapy with the along with the cystectomy, that is removal of the cyst, which can have an improvement of the outcome. However, we should also counsel her that this might lead to a reduction in the ovarian reserve. But first we'll explain the benefit of the surgery, and then we will explain the possible risk of the reduction in the ovarian reserve. Additionally, we can also tackle with the uterosacral disease with the help of diagnostic laparoscopy, which will further improve her pain and fertility prospect. And if adhesions are present, adhesiolysis will also help because restoring the normal anatomy will increase chances of a natural spontaneous conception.
We'll say that the probability of having a normal conception or a natural conception depends on the the tubo-ovarian anatomy. If the anatomy is distorted or if the anatomy is not well maintained, it is less likely that the couple can conceive in a natural conception.
So we will focus on the natural conception as far as possible and discuss the other options for later.
Okay, so before you proceed into actual surgery, put the scope inside, I would like to call upon other faculty members, apart from myself and Palaniappan. Dr. B.S. Jodha is here. Dr. Pratibha Rai, I can see.
Yeah. Yes, sir. Yes, sir.
You have any
Am I audible? Am I audible?
Yes, audible.
Yes,
Dr.
sir.
Could not make it because
according to me, surgery is the better choice. And after removal of that tumor, must send it for biopsy to rule out whether it is benign or malignant, or because chances of carcinoma is much more with endometriosis and ovarian endometrioma. So first you rule out and you convince the patient, then we are trying our best. And in worst case, if you have lost your ovum, we can donate ovum, and chances of fertility is there in IVF.
Oh, that's a later choice, which will come to that
later. Last but not least.
So before that, I would like to know any more question on the varieties of medical management and preparation for the surgical management. You have any more question? That's what I wanted to ask you. Or you will allow them to go into surgery. They are waiting with the scope in their hands.
The first choice is medicine, and they have discussed very nicely. But in endometriosis or endometrioma, without surgery, full cure is not possible. So surgery, we have to do surgery, especially in this type of case, because lots of additions are there and they hinders the pregnancy. So
Dr. B.
surgery should be done.
Dr. B.S. Jodha is here. Dr. Jodha, are you here? Okay, I think I saw Dr.
Sir,
Jodha once. Yes, madam.
sir, I think before taking any decision for surgery, we have to weigh that we are not disturbing the fertility, because we have to keep in mind about the fertility, future fertility. Accordingly, we have to proceed.
Okay. So, madam, what is your suggestion about your counseling with the couple? What do you want to point out here? They are in the process of counseling and they are going to take a final decision about laparoscopy. You have any more suggestions?
Sir, actually, in some part of our country, even we are very much, even we are doing ART, but many of the patients, they are not ready for ova donation. They need children from their own ova. That's why this has to be keep in mind, because in our center in AMU JNMC, we are also having an ART center, but most of the our patients, they need their own matlab children from their own gametes, not from donated gametes. So this we have to think. We have to see the family, the couple, what are their prospect. Then
Okay.
only we
In
decide.
your center also, madam, AMU.
Patient has double uterus on both sides. If we have damaged
I just
by
wanted to ask
surgery,
Dr.
one side
Ishrat.
of ovary is damaged, then another is there, and from that side, ova can we can
No, it's
collect.
okay. We'll come to that later. But Dr. Ishrat, I'd like to ask you in your center also, before you go into ovum donation, suppose the other couple has agreed. Before that, do you like to have a removal of the affected ovarian cyst or the concerned fallopian tube, or you go straight away for the ovum in presence of the ovarian cyst? I mean, endometriotic cyst. What is your policy there?
So mostly in a large endometrioma, we have to remove that endometrioma. But every attempt should be made to preserve the ovarian tissue, even in the same ovary. We
Correct.
can preserve some ovarian tissue in the same ovary, and then we can see.
Okay, so now we are, let us delve into deeper into the pelvis and go with the laparoscope inside. My friends Manasa and Nikhil, they are waiting with the scope. So have you entered the abdomen now? Now tell me, what are you going to do from the beginning till the end? Just tell us a brief outline of the procedures that you need to do. What is the first thing that you do after inserting the scope?
Assuming that the scope has been inserted properly and we are inside the abdominal cavity, we will first have a bird's eye view of the entire abdomen. Whether the uterus appears normal or not, we will look for both the ovaries, both the fallopian tubes, whether they're appearing normal or not, whether there are any obviously visible adhesions that we'll have to deal with. Then we will um, then we will move ahead and look on the normal side. Once we'll have a look on the left side to see if there's any additional pathology which might have been missed on imaging or examination. We'll then go over to the affected side and characterize the cyst and where all it is adherent. It might be adherent to the uterus, it might be adherent to the lateral pelvic wall.
In the evaluation
Might be adherent
process,
to the
do you take calls on the depth of the pouch of Douglas, relationship of the fallopian tube with the ovary? Additions you have talked about, but these are two things that you didn't mention. So are they important from
Yes, sir.
point of view of surgery and its fertility related issues?
Yes, sir. This addition, the relationship with the ovarian fallopian tube is important in the context of what can be the chance of success of a spontaneous pregnancy later on. If there are adhesions of the fimbria with the tube or the ovary with the tube, or the anatomy seems to be grossly distorted, then despite ovulation, also the chance of the fertility later might be in question. That might be one of the things. Then the pouch of Douglas, of course, since we are considering uterosacral nodules also, there might be adhesions in the pouch of Douglas that we might want to clear, which might also be adherent with the tube as well. The tube might have gone posteriorly. That will distort the anatomy even further. So we would want to do a restoration of the anatomy, and so we'll want to see all of these things.
Okay, now what do? You have come to you have seen the healthy ovary and you have reconfirmed that it is healthy, which was confirmed by the ultrasound and MRI. And now you're seeing that the ovary is healthy. You can see 3 or 4 follicles there. But you come to the disease side and you see a mass of 5 into 4 centimeter, consistent with your clinical ultrasound and MRI findings. Now, what do?
We have to, the definitive treatment will be the excision of the cyst. And we have to be very particular about the thing that the normal ovarian tissues should not be taken away, because she is a case of, she's an alligravida. So how much ever normal ovaries we can save, that has to be saved. But the entire disease, the cyst has to be excised along with the cyst wall, so that it prevents the recurrence as well.
Manasa, you will puncture the cyst or you will enucleate the cyst
No, sir,
in toto?
Excise the cyst.
In toto?
Yes.
Yes.
Just like a dermoid, you want to excise it toto?
Yes.
Yes,
yes, sir. Yes,
yes,
sir.
How easy is it? How difficult is it?
It is difficult only, especially considering that we want to save as much normal ovary as possible. We have to find a interface planes. The proper planes will have to be delineated.
Okay, sorry. I would puncture the cyst first, see whether it is chocolate, right?
Yes.
Having said, and then I will get a cyst wall and I will peel it. I will not try to remove the entire cyst en masse, because how are you going to take it out? 5 centimeters, isn't it? You can't take the cyst out entirely.
Yes,
If you puncture it, is easier to remove the cyst wall and keep some portion of the remnant normal ovary.
Yes.
Okay.
That is what Dr. Ashish was asking. What
Actually, I would like to just have a different opinion from Palaniappan. You see, yes, look is important. Suppose the laparoscopic look of a chocolate cyst, even a small or the peripheral cyst or the so-called satellite cysts, they are there. I think that, yes, puncturing for a diagnostic point of view is already done enough diagnosis with MRI, isn't it? And so I'd rather just try and see the ratio between how much healthy ovary I can see and how much unhealthy ovary I can see. Is it possible to clearly demarcate between the healthy and the unhealthy ovary? If it is possible, I'll simply go with if I have a harmonic or if I have a monopolar, I will give an incision, put an incision on that more towards the affected side in order to preserve the healthy ovarian follicles. And then try and see, put a tentative pull with the help of a grasper, and the cyst wall automatically they comes out of the distance. That's what my experience goes. And maybe it may be different in different cases. But I think that if it is possible to, with a few tentative pull, it's like a trial of labor. If it is few tentative pull, if it comes out, then it's fine. Otherwise, I'm always there. My scope is always there. My monopolar needle is already there to puncture and take out the cyst individually. But I think that is one problem in that the deep-seated follicles which are containing the cyst material, I mean the chocolate cyst material, endometrioma, they remain and they create problem. These are chief causes of recurrence in the future. So that is my opinion about this. Now you go according to the in front of you, whatever the findings are, but looks are
That's
very
a point I'd like to.
Yes.
So additionally, the point that I like to add is rupturing the endometriotic cyst might also be associated with an increased rate of recurrence, as the endometrial cells might be seeded in the peritoneal cavity. So for that one reason also, I would not want to.
So you cannot say things in blanket that we'll do this, I will do that. It depends on the situation that is prevailing in front of your eyes. But as I said, this is very important to see how much healthy. Usually the healthy ovary can be seen close to the hilus of the ovary. Easily the healthy ovary can be seen, that how much is the proportion of healthy ovary and how much is the proportion of the unhealthy ovary. That is usually visible. And you can, the things are also made easier that way if you do that. And of course, that what Palaniappan said is also very true, because that becomes easier and diagnostically it becomes more comfortable for the surgeon. And also, when if you think about in terms of preserving the healthy ovaries follicles, then I think it is okay.
Sir, one question from my side to Professor Ashish.
Yes.
Can we collect healthy ova before surgery for future IVF in this type of case?
Of course, it can be done. It is, I think,
It
whether
will be better. I think it will be better to collect mature ova previously and then we do surgery.
Madam, many of the people in the fertility circle, they do it in two steps. One is that once you complete the cystectomy, take out
Yes.
all the cyst material outside, give
Yes.
some time for the AMH to regrow, when
Yes.
it needs to recover, and then
Yes.
do this, then it gives a result, better result.
Yes.
You are
Yes.
doing frozen embryo transfer, FET, that is all right. But
Yes.
then simultaneously with the cystectomy, that is not favored by many. They say
Yes.
that you
In
see
rare
that
cases. In rare cases.
you see that
No. See, if other ovary is normal, I don't think you need that.
Yeah.
There is no need to
There's
think
no need.
because other ovary is normal. It's only unilateral.
Yeah.
Okay, so there is no need to think of any freezing.
Simultaneous process. Yes, that's right. So I think that we are coming gradually to the end of our discussion. 1:30 is the time limit we have set for ourselves. Only 1 minute, 2 minutes left. I'll invite one or two more questions. Palaniappan, you and I had enough questions. Let us see the other examiners, any point of view or any other questions. Dr. Jodha is not there. I think
he's not joined.
He's not joined. Okay.
Manasa, Nikhil, you need to think in terms of giving some medical management after the surgery also. You may not be able to fulgurate all the points in the peritoneum. You may not be able to do a complete surgery. Endometrioma, you will resect very well. But there may be flare-up of spots here and there. So you're not wrong in giving either a Dynegest, Ilagolic, whatever after the surgery also for some time. And then probably stimulate ovulation and then think about fertility concerns. That is all from my side, Ashish. Anything else you want to say?
Finally, actually, before closing this discussion, I think we are coming away from the days when we used to give GnRH agonist and then going for the surgery. Postoperative, there's not in use anymore, but preoperatively using this GnRH agonist and going for the surgery is gradually becoming out of practice.
True.
Because of the loss of plane of surgery, difficulty, more oozing, and recurrence of endometriosis and recurrence of adhesions in such cases. So with that comment, I think I will close this discussion today. Thank you very much for all the faculty members, for the students. They have done wonderfully well. Manasa and Nikhil, my dear friend Palaniappan has been excellent. Dr. Pratibha Rai, thank you very much. I think two of the faculties could not join here, but overall, it has been a good discussion and a good interaction. And I think if we all agree, the students have passed.
Yes.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you so much, Ashish sir, Palaniappan sir.
Very nice number. Very
comfortably. They have passed comfortably. It is not a question of grace.
Yes.
I know Palaniappan is very poor in giving graces.
No.
No, they don't
I'm
need.
very happy with both of them, no doubt.
Okay. So I'll close this discussion and I'll call Hafizur. Hafizur, are you there?
Dear sir.
Thank you so much, sir. Thank you for giving this opportunity, sir.
Thank you so much. Thank you. It is wonderful.
Thank you, sir.
Sir, can you stop sharing your screen?
Yes, sir.
Yes.
Thank you.
Thank you so much, Dr. Manasa and Dr. Nikhil, for your. I think the examiner can much better say how they have performed.
Examiners have already given marks.
Yes, sir. Thank you so much. I would like to thank you, the entire team of KEM Hospital and Seth GS Medical College. Dr. Padmaja, madam, are you there? Their HOD is there. Would like to have any comments?
I saw her, Padmaja ma'am. I saw her, but
Dr. Himangi. Dr. Himangi is there.
He is there. Yes, Dr. Himangi is there.
Yes, Dr. Himangi, would you like to say any comments?
I think
their
students' performance said it all. So she doesn't have any more extra comment. So
thank you, sir.
I think we'll close this discussion.
Thank you so much. Thank you so much to the entire team of KEM Hospital and GS Medical College and all our faculties, Ashish sir, Palaniappan sir, Dr. Pratibha, and Dr. Bijat Zoda couldn't join. Dr. SP Jai sir had some emergency. Ashish sir, we need to have a little bit of change because Dr. Ashish Kale is in OT said he is not yet joined. So I think we may have to shift to the program for the quiz. I think quiz team is ready. Dr. Nazia, Dr. Archana, madam, are you there?
I think, sir.
Nadia, can we have at least take some time and start the quiz? If when Dr. Ashish if join, we can have.
Approximately how much time Dr. Ashish Kale will take? Do you have any idea, Hafizul?
Sir, I don't have much idea because his assistant had a talk. So maybe we can take on the quiz, or at least they can have start in joining the program. If he joins, we can have it shift to later.
So I think we'll continue with the quiz and then come back
Yes,
to
sir.
surgery of endometriosis later on when he is free. Okay, is that okay with all of you?
Yes, sir.
Yes.
Palaniappan has conveyed thanks to all of you, and thank you, Palaniappan. It has been exceptional working as a co-examiner with you. Thank you so much.
Yeah, Palaniappan sir has always been very
So,
different.
I think Nazia will conduct the quiz, or Archana is there. Who will conduct the quiz?
No, sir. Actually, ma'am, her daughter's marriage is closed, so she is very busy in that. I will conduct the quiz.
Okay.
And
Anyway, who is faculty one? Dr. Ashish Kale, are you there?
No, faculty. I think it is not Ashish Kale. It is somebody else.
Sir, I couldn't know. But anyway, we'll see him. Pratibha ma'am, can you mute yourself?
Yes,
Please.
yes.
Yeah, please, Nazia, maybe you can take some time and have this quiz because our Dr. Archana said her daughter is having marriage, I think, and she'll be busy.
Sir, it will take around half an hour. So if
you can take your time.
Sir, if you give me permission, I will make the host live. That will show the quiz pin and QR code. So it will take some time for participants to join.
No, we know that. We know that, Nazia. We have been conducting quiz. So I think it doesn't take much time.
Obviously.
Please go ahead. Please go ahead.
Go ahead, please.
Okay, sir. Okay, sir. So I think participants will also be ready with their Kahoot app. So I'm loading the game pin now.
Dr. Pratibha, kindly mute yourself. Yes. Thank you.
So this is the game pin 9286184, and there is a QR code. By scanning this QR code, participant can join the quiz. So we are waiting for the participants. Dr. Nikhil, Manasa, they both have joined. NS, this is a request to participants. Please join with your first name. NS, then it will be difficult to recognize you. So please join with your name. NS, please rename yourself. And who is this 1710? Please rename yourself with your first name. Bushra, Ariza, Jyoti, Satvika. I think participants are joining. Dr. Hema. Who is this SNY? Please join with your first name. Faculty. So faculty is also joining in this quiz. Dr. S. It is 1:36. Hafizur sir, up to what time we should wait for participant?
Yeah, you
Dr.
can take
Nadia.
time. Maybe you can
Yeah,
take
Dr. Hafiz, just make one announcement that the 3 participants will get the books first, second, and third prize.
Yeah, ma'am, you can do. So our Sheila ma'am saying the first 3 participants, the winner will get the prize. And whatever the prize, madam, we can make keep surprise or you can tell, ma'am.
No, that these are books only, but that we will
Okay.
tell them which books later. Okay.
Okay, ma'am. We'll sell.
Ma'am, for the quiz coordinator, I
Special prize. Special prize. Okay.
A very embarrassing question, I must say.
No,
The chairman of
not at all.
ICOG.
I appreciate that. I appreciate it. Okay.
Actually,
And nobody is the unsung hero or unsung hero here.
Yeah.
Everybody is appreciated and acknowledged.
So we are still a student.
To Sheila माने everyone is a student. ये बात तो शीला भी माने.
Yes. Yes.
Good.
See, if you take now, it is 42 years of experience, Nazia.
Yes, ma'am. Ma'am, I read your book on PPH, and one of my talk was fully inspired by you. Your introduction of golden hour and PPH.
My God. Just imagine Sheila. The entire
Nice
talk
to hear
was
that.
dedicated to you. Yes.
Nice to know that. Thank you. So again, a special prize, Ashish.
No, we don't have followers, so we don't get prizes. That's the problem.
Thank you, ma'am.
Extremely generous chairman of ICOG we have this time. So whatever the demands all over the years have been accumulated so far in ICOG, please place it to her. She will give us all prizes.
Oh, yeah, sure.
My pleasure. So there are 45 participants till now.
Good to go. Nazia, you can start now. I think 45 is good number.
Okay.
If the numbers are joining, sir, maybe she can wait 2-3 minutes.
50, 51.
I think 50
so
you
maybe
can the target.
Couple of minutes.
Normally we do it at 50, no? That's why.
Because some of the students are maybe joining new and they need some time or.
Lot of participants.
56.
Yes, sir. That's good.
So see, Nazia, how much time has it taken? Only 5
less than half an hour. 30 questions only, sir, for 20-25 seconds each question.
I think you can start now because it is already.
Okay, sir. Just for all the participants, please ensure that your network should be good. Otherwise, if you exit from the quiz, then your marks will be less. You miss. You cannot enter. You can enter, but you can miss. So please ensure your network. So I think we should start now. Sir, your permission, Ashish sir?
Yes.
Sir?
Go ahead.
Yeah.
Okay, sir. Now, all the participants, be ready. Now we are starting the quiz on endometriosis. Your first question. Which of the following best describes endometriosis? Chronic inflammatory condition, purely a gynecological disease, is it a hormonal imbalance or an autoimmune disorder? Best describes endometriosis. 3, 2, 1. So the correct answer is chronic inflammatory condition. Endometriosis is best described as a chronic inflammatory condition. Now the scores. Save is on the first position, followed by Sondrea and Mariam. Next question. Which molecular abnormality is most strongly associated with progesterone resistance in endometriotic implants. Down regulation of progesterone receptor B, overexpression of estrogen receptor beta, increase aromatase activity, or loss of P10 expression. So correct answer is down regulation of progesterone receptor B. And scoreboard. Now Abarna is on the first, Anu is on the second, and Shadan is on the fourth, followed by Ariza. 1710 is fifth. Next. 26-year-old lady with severe dysmenorrhea and heavy flow was diagnosed with endometriosis. Her pain is correlated with depth of penetration, number of sites involved, CA125 level, or the stage of disease. So correct answer is depth of penetration. Pain is correlated with depth of penetration. Now the scoreboard. Abarna is on the top, followed by Shadan, Ariza, 1710, and Vidushi. Next. The most common site of endometriosis involvement in the intestine is ileum, cecum, appendix, or rectosigmoid. The answer is rectosigmoid. Most of endometriotic deposits are in the rectosigmoid. So now the scoreboard. Archana is on the top, followed by Nikhil and Anaya. Next. Correct statement regarding adolescent with endometriosis is adolescent endometriosis is rare. Laparoscopy is first line treatment. Empirical hormone therapy is appropriate and imaging is not useful. Which is correct statement? Correct statement is empirical hormone therapy is appropriate. Imaging is always useful. Laparoscopy is not first line. Medical therapy is first line. And adolescent endometriosis is not a rare entity now. So only three correct answers. Now the scoreboard. Nikhil is at the top, followed by 1710, Archana, Manasa, and Nayana. Next. Which of the following operative procedure are least likely to cause scar endometriosis? Hysterotomy, hysterectomy, myomectomy, ventrofixation. Correct answer is hysterectomy. In hysterectomy, uterus is not opened. In cesarean, hysterotomy, even in myomectomy, endometrium is opened, and also in ventrofixation. While in hysterectomy, endometrial cavity is not open. That's why chances of scar endometriosis are least. So now the scoreboard, Nikhil on the top, followed by Abarna. Next. Which of the following pain type in endometriosis is least responsive to hormonal therapy? Dysmenorrhea, cyclical pelvic pain, central sensitization pain, or dyspareunia? Which is least responsive to hormonal therapy? It is central sensitization pain. Dysmenorrhea, dyspareunia, and pelvic pain, they all respond to hormonal therapy, but central sensitization pain least responsive to hormonal therapy. Now the scoreboard. Nikhil followed by Archana and Manasa. Next question. According to recent recommendations, A normal transvaginal ultrasound should completely rule out endometriosis, prompt immediate surgery, not exclude endometriosis if clinical history is suggestive, only be used in infertility cases. Transvaginal ultrasound. Correct answer, it doesn't exclude endometriosis if history is suggestive. Okay, so 10 correct answers. Now the scoreboard. Nikhil and on the top, Manasa and 1710 are on the second and third. Now Archana is on the fourth and Anu has taken lead at fifth position. A ultrasound of a 45-year-old woman with AUB and dysmenorrhea is shown. You have to see this ultrasound picture. What is the diagnosis? Is it a uterine leiomyoma, adenomyoma, endometrial polyp, or a endometrioma? Look at this ultrasound picture. The correct answer is adenomyoma. It is not endometrial polyp. The salt and pepper appearance on the ultrasound, this is not a circumscribed mass, which is a fibroid, and it is not having a ground glass appearance in ovary. So it is an adenomyoma. Now, Nikhil is maintaining on the top, followed by Manasa. Next. Deep infiltrating endometriosis is defined by invasion to a depth of more than 2 millimeter, more than 3 millimeter, more than 5 millimeter, or more than 10 millimeter. How you define deep infiltrating endometriosis? Correct answer is more than 5 millimeter. Then you say it is a deep infiltration. So now Nikhil, Manasa and Archana. Next. A benign ovarian cyst that shows high T1 and low T2 signal, T2 shading on MRI. Is it a fibroma, ovarian fibroma, endometrioma, serous cystadenoma, or parovarian cyst? Correct answer is endometrioma, which is having high T1 and low T2 signal. That is called T2 shading. So now the scoreboard, Nikhil is still on the top. Next. Which imaging modality is preferred first line for suspected deep endometriosis? Suspected deep endometriosis, either transvaginal ultrasound, MRI, CT scan, or diagnostic laparoscopy. Which is the first line? First line is always transvaginal ultrasound, not confirmatory. You can confirm it with MRI, but first line is transvaginal ultrasound. Now the scoreboard, Nikhil, Manasa, Archana and Abarna. Next question. Which is an emerging non-invasive diagnostic method for endometriosis that has shown high accuracy in the recent trial? This is not validated, but recently we are using either 2D transabdominal ultrasound, MRI, PET scan with FDG tracer, or salivary microRNA profiling. It is salivary microRNA profiling, which is being used in the recent trial, and very promising results are coming with the salivary microRNA profiling. So this is the emerging trend in the diagnosis of endometriosis. Now the scoreboard. Now Manasa is on the top, followed by Nikhil. Next. Which statement regarding the diagnosis of endometriosis is most accurate? Number one, diagnostic laparoscopy is mandatory before starting any treatment. MRI is recommended as first-line imaging in all suspected cases. Empirical treatment can be initiated without surgical confirmation, or ultrasound has no role in diagnosing deep endometriosis. So easy one, empirical treatment can be initiated without surgical confirmation, because we are not going to do laparoscopy in each and every cases. We are doing ultrasound, or we are suspecting by clinical history, and we can start treatment. So now the scoreboard, Mansa is still on the top. Next question. What is the recommendation regarding CA125 in endometriosis? Is it recommended for diagnosis, recommended for screening, not recommended for diagnosis as well as screening, or is it useful for staging the disease? So the correct answer, it is not recommended for diagnosis or screening. Okay. So now the scoreboard, Nikhil again climbed on the top. Next question. Now we will ask you about treatment of endometriosis. Which of the following is an effective first-line hormonal treatment for endometriosis-related pain? Dynogest, danazol, antiprogestogens, or aromatase inhibitor, which is first-line hormonal treatment for endometriosis-related pain? So the correct answer is Dynogest. First line, we use progesterone, that is Dynogest, which is very good in decreasing the pain related to endometriosis. Okay, danazol is not commonly used, aromatase are also not used. First line is Dynogest. Now Nikhil is still on the top. Now Abarna has climbed to 4th position, and Sana Naz is highest climber in the below list. Next. 30-year-old lady with dysmenorrhea and infertility was prescribed an intranasal spray containing GnRH agonist. This drug is leuprolide, hysteralin, naferlin, or goserlin. Intranasal spray GnRH agonist. Intranasal spray are usually of naferlin. Okay. So now the scoreboard, Anu has climbed to 4th position now. Next question. Linzagolix is a novel drug in endometriosis treatment. It requires which of the following strategy to mitigate the side effects of linzagolix? Concurrent NSAIDs, low dose add-back hormonal therapy, high dose corticosteroids, calcium supplementation, which is used to mitigate the side effects of linzagolix. It is 12 correct answers. It is low dose add-back hormonal therapy, which is given along with linzagolix. Okay. So now the scoreboard. Nikhil and Mansa are continuously replacing their position, and someone, Dr. S, is the highest climber in this round. Next. Which new oral therapy for endometriosis has been approved and represents a shift towards easier at-home management? Is it Depot GnRH agonist, letrozole monotherapy, relugolix, estradiol, norethistérone combination, or danazol? Which is the new oral therapy that has shifted towards the at-home management? The answer is relugolix, estradiol, norethistérone combination. Means relugolix with the low dose add-back therapy is the new oral therapy. Okay. Now, Manasa is still on the first, followed by Nikhil and Archana. Next question. According to Eshere, after conservative surgery for endometriosis, post-operative hormonal therapy should be offered to improve spontaneous fertility, reduce the recurrence of pain, to prevent adhesion, or to increase the ovarian reserve. After doing conservative surgery, we give hormonal therapy for, it is to reduce the recurrence of pain because it doesn't improve the fertility. Okay, so it is given for those patients who are not desirous of immediate fertility. So now the scoreboard, I think it is same. Manasa has given 3 correct answers in the row. Next. After surgery for endometriosis associated infertility, which tool is recommended to guide further fertility management? Which is the best tool? RASRM score, AMH alone, endometriosis fertility index, or ultrasound ovarian score? It is endometriosis fertility index, not AMH alone, because it consists of 10 components, 5 of history, 5 of about surgery. They predict future spontaneous fertility within 3 years. So endometriosis is nowadays only validated tool to correctly predict the fertility after surgery. Manasa, Nikhil, Archana, Abarna, and Anu. Next. A woman with endometriosis fertility score of 3. Post surgery, she should be advised expected management for 12 months, repeat laparoscopy, early ART, or post op hormonal suppression. This is early ART because endometriosis fertility score 3 is a low score. That means the chances of spontaneous pregnancy are less. So she should be advised early ART. Now the scoreboard, I think it is same. Next. Which statement about endometriosis associated infertility is correct? Surgery always improves fertility. ART should be delayed until surgery. Suppressive hormonal therapy improves spontaneous conception. Or ART is appropriate, without prior surgery. Surgery is missing in green. So correct answer is ART is appropriate without prior surgery. Because surgery not always improve fertility, there is risk of decreased ovarian reserve after surgery. ART should not be delayed in every case until surgery, and suppressive hormone therapy doesn't improve conception. ART is appropriate before going to surgery. So the correct answer is now Manasa, Nikhil, and Abarna is now on the 3rd position. Next. Which therapy is not recommended for endometriosis associated pain? Anacids, oral progestins, LNG IUS, aromatase inhibitor monotherapy, which is not recommended. 3 of them are recommended. One is not recommended for endometriosis associated pain. So the correct answer is aromatase inhibitor monotherapy. It is not recommended for pain. Other 3 are recommended. Scoreboard is same. Now next question. Which is the strongest indicator for surgery in endometriosis according to Eshere? Asymptomatic endometrioma, infertility, pain refractory to medical therapy, elevated CA125 label. So the answer is pain, which is refractory to medical therapy, is the strongest indication for going for surgery in endometriosis. Scoreboard. Priyanka. Now Priyanka has climbed to 4th position. Next. Which statement regarding surgical management of ovarian endometrioma is correct? Number one, cystectomy increases the recurrence. Cystectomy reduces pain compared to drainage. Surgery improves the ovarian reserve, or surgery is mandatory before ART. Correct answer is cystectomy reduces the pain compared to drainage of the cyst. Now the scoreboard. I think the scoreboard is stuck with Manasa at first, Nikhil at second, Aparna, Priyanka and Archana. Next. Surgery is not recommended in infertile women with endometriosis when ovarian endometrioma is about 2 centimeter, deep endometriosis is present, pain is very severe, hydronephrosis is present. We are not going to do surgery in which of the following case? Correct answer is for a small endometrium of 2 centimeter, we are not going to do surgery in infertile women while we are doing surgery in all other cases. Abarna is climbing to third, followed by Archana. Next question. What is ASHRAE's stance on complementary and alternative medicine for the management of endometriosis? This is new in the management of endometriosis. Is it the first line therapy? Is it a strongly recommended therapy? Or it is no evidence to recommend this? Or is it superior to the hormonal therapy? This is a new form of therapy, but there is no evidence till now to recommend a complementary and alternative medicine for the management of endometriosis. Scoreboard. Now Nikhil again climbed to top, followed by Manasa, Abarna, Priyanka and Archana. Anamika in the lower list is the highest climber. Next. Most accepted explanation for high recurrence rate of endometriosis after doing hysterectomy in bilateral salpingo-oophorectomy is persistence of microscopic disease, de novo metastasis of peritoneum, immunological dysfunction, or extra ovarian estrogen production. Which is the explanation? So the answer is extra ovarian estrogen production, because apart from ovary, our body, peripheral body fat is also producing estrogen. So because of that estrogen, there is recurrence of endometriosis even after doing hysterectomy and bilateral salpingo-oophorectomy. Now the scoreboard, this ends the quiz, and now we will go to the podium to see the result. Congratulations all who participated. Abarna is on the third position. Manasa is the runner-up on second position, and the winner of today's quiz on endometriosis is Dr. Nikhil. Priyanka is on the fourth and Archana is on the fifth.
Congratulations, Nikhil, Manasa, and Abarna. I think those who presented the case had the advantage of reading the subject well. Right?
Thank you.
Thank you,
Yeah.
ma'am.
Yeah. Yeah. Okay, all of you share your address later on, postal address. Okay?
Please switch on your cameras so we can see the winners. Nikhil,
Yes, sir.
Dr. Nikhil, Dr. Manasa.
Nikhil and Manasa can be seen. Abarna is in the other side of the login page, so maybe you will not see Abarna because they have joined the different link.
Okay.
So congratulations, Abarna, Manasa, and Nikhil. This is one of very rare occasions where the preparing students have become in the top two. I think only once happened prior to this, but most of the time other. But it is also important, like Sheila Mane madam said, the students, those who have prepared, and how they can do quite good in this situation. So congratulations again.
Yes, congratulations, Nikhil and Manasa. You have done wonderfully well in the case discussion also. And now
Yes, sir.
you have won the first and second position. You don't need the book. So now the Sheila madam will give a book to the faculty who questioned them, who crossed them.
So congratulations once again. Okay.
Yeah.
Thank you, ma'am. And
Very good.
Nazia, thank you for conducting it very well. Yeah.
Thank you, ma'am. Thank you very much for giving me the
And
opportunity.
Nazia, thank you for ma'am. I will give you some different prize and special prize as Sheila madam committed. So thank you so much, the quiz committee. Yeah, Ashish sir, anything? Sheila ma'am, I just wouldn't like anything more.
I think it was wonderful. I think I hope all the postgraduates, those who have joined this, are benefited a lot. I think endometriosis chapter is made pakka for you with the quiz, with the case presentation.
Yeah.
And occipitoposterior presentation, I think that was very well demonstrated by Dr. Rekha Bharati and the inputs from everybody, like Dr. Ashok, Dr. And was very, I think, was very helpful for all of you. So even though it appears simple, these are the books. When it is discussed here, the senior teachers will tell you all these points, which will be very useful. And you remember it when it is discussed. See, when you read, also you remember. Okay.
Yeah.
So when you read, you remember, but when you present, you learn. Okay. And when you get involved, you don't forget.
Yes,
Okay.
and that's very good. And there is a percentage associated with this, Dr. Sheila Mane.
Yes.
When you read this, you retain only 10% of that. When you take part in the discussion and case discussion, you retain 30%. And when you do the laparoscopy, you retain 100%. So that is the
Yeah.
rule about endometriosis.
Yes. So I think Manasa and Nikhil got the maximum benefit today.
Yes.
Anyway, I think and all the participants. So we'll continue this. And I would like the postgraduates, those who have joined today, to spread the message. See to it that next time you bring 10 or 20 more postgraduates with you to attend this class, because we want it to benefit everybody and to clear their exams. Not only this, you learn so much which will help you forever in your practice also. Okay. So thank you, Dr. Ashish, Dr. Hafiz, Dr. Nazia, and Dr. Ashok. I think if he is there. Thank you all. Yeah.
Actually, I think another
Thank you, sir. Thank you,
announcement
sir.
from the ICOG point of view, that all these discussions will be there in the ICOG website. So I think visit the website and go back and see all these case discussions and all these lectures, etc. That you will be tremendously benefited. You will be hugely benefited. So this is one thing that the ICOG is doing for all postgraduates.
One
Those
more.
you who could not attend today will be benefited by the recordings. And also
Yeah, and we are also starting the Gurukul program, which will be done by Dr. Ashwath Kumar. We will soon announce the date and the flyer will come. And not only this, you people can also attend our master class, the certification courses. Okay. Even those also you people can attend. And one more thing I would like to announce, like after you finish, next time we will share the flyer, Hafizur. We are
Yes, sir.
planning to start the hybrid fellowship of critical care. Okay.
Yes, ma'am.
So because we find that very few people join, so we will have online classes 5 months, and only 1 month there will be physical. So we will see that we will all of us will sit together and we'll make it happen, because that is the need of the hour today. Thank you, Vandana.
Thank you.
Thank you so
madam.
much, Dr. Sheila Mane. Very innovative ideas and always thinking about our dear postgraduates. And I think that ICOG will move progressively forward under her able leadership. Thank you, Dr. Sheila Mane. Thank you
With
so
all
much.
of you together. Thank you.
Yes, ma'am.
Thank you so
Thank
much,
you.
everyone.
Thank you, Sheila Mane ma'am, Ashish sir. So for the session 3, Dr. Ashish Kale could not make it because of some unforeseen circumstances. So we would like to have this topic in future in next one of the program. I know many of the students were waiting for this. So for today we'll not be able to do, but in future we'll definitely do this.
Correct.
So I'd like to now sincerely thank you, our President, Dr. Bhaskar Pal, sir, ICOG Chairperson, Dr. Sheila Mane, Madam, then Chairperson-elect Dr. Ashok Kumar, Vice Chairperson Dr. Sadhna Gupta, FOSI Secretary Dr. Suvarna Kadilkar, Madam, Secretary Dr. Pratik Tambe, and of course to Ashish Mukhopadhyay sir for always being there with this program. Now I'd like to sincerely thank for the first session, that is a mechanism of labor in occipital posterior position, Dr. Rekha Bharti from Safdarjung Hospital for her excellent demonstration. As Ashish sir said, this program will be in record, so student can go later on and have a recapitulate on them. We'd like to also thank to the entire team of KEM Hospital, HOD Dr. Padmaja Y. Samant and additional Professor Dr. Himangi Sudhakar Warke, and for their excellent presentation of the students, Dr. Manesha and Dr. Nikhil Arjun Bharad, for your excellent presentation. And of course, the faculties, as Dr. Ashish sir, Dr. Palaniappan, Dr. Pratibha Rai, and Dr. S.P. Jaiswar, Madam, could not make for her some very familiar emergency. And for the last session, that is the quiz program, which has been always be exciting for the students, and more students are coming and joining this program, and I'm sure this is one of the way additional going for encouraging the students to learn on this. So I'd like to thank Dr. Archana Kumari, the Chairperson Quiz Committee, and Dr. Nazia Istrat for excellently conducting the quiz program. So I'd like to thank you for this program on this Sunday, and I would like to come back with another program, exciting program on second Sunday of the next month.
Thank you, sir.
Yeah. Thank you so much. Thank you, Ashish sir and everyone, and thank you all the students.
Thank you. Bye-bye. Thank you.
Bye-bye. See you.
Thank you.
And thank you, the host team, that is from the FOSI Next Gold team and everyone. Thank you so much.
Thank you so much, everyone. So from here, I'm ending this meeting.
Yeah, you can stop recording.